Good morning, Ray.
Good morning, Dr. Bischoff. How are you?
Very good. I'm ready.
Okay, I'm going to change your sign there.
Perfect. Buenos días.
Buenos días.
¿Listo?
Listo. Vámonos. Empiezas, luego yo y luego Alberto.
Perfecto.
Y haces tu cierre triunfal con fecal incontinence y AC procedures.
Muy bien. Para ese, yo tengo la película del malón, pero si no hay tiempo, yo nomás digo que va a estar disponible.
Tiempo es lo que nos sobra
¿Tú crees?
en esta vida.
¿Tú crees?
Voy a poner en mute mi micrófono porque ahí viene el día.
Está bien.
Creo que tenemos que llevar al personal, al team del centro colorectal a un grupo de sanación.
¿Por qué están todos enfermos?
La enferma, bueno, Elisha no viene, hasta
Sí.
tarde. Annie no viene
¿Por qué?
porque se enfermó su hijo.
¿De nuevo?
Entonces mandó un mensaje de que cualquier cosa, por favor, le avisemos a Elisha.
Uf.
Y la semana pasada
Ah,
sucedió lo mismo. Se enfermó Elisha, se enfermó Peggy, todos. Por
hombre,
eso te digo que estamos un equipo de sanación.
pues sí.
Dr. Bischoff, I'm going to go ahead and turn on the webinar if that's okay.
Sounds good.
Okay. Good morning, everyone. Dr. De La Torre, do you want to kick things off?
Let's do it. Thank you, Ray. Good morning, everyone. Good afternoon, good night. Today is the second day of this conference. Welcome again. We're going to start with the lecture about total colonic aganglionosis. And this is going to be dictated by Dr. Bishop. We already presented her yesterday. So Andrea, please go ahead. You are muted.
Sorry. Good morning, everyone, and welcome to day 2 of the Hirschsprung course. We are now going to talk about total colonic aganglionosis. So let's discuss 3 possible scenarios. The first one would be the ideal scenario, meaning that you suspected total colonic aganglionosis. So you're going to do your leveling colonic biopsies and an ileostomy. We always recommend, in cases of colorectal, doing divided stoma. So you would have your ileostomy and your mucus fistula, because as I'm going to speak a little further in the lecture, we recommend this ileostomy to stay in place for a long time, and you want to be able to flush this colon. And when we open a stoma in all of our colorectal patients, we recommend cleaning the distal portion of the bowel, again, because this is going to be there for a long time. So this is the ideal scenario. You suspect it, so you're going to do your leveling biopsies of the colon, and you're going to do a very nice ileostomy because this will be in place for a long time. Now, the second scenario is that you did not suspect you were dealing with total colonic aganglionosis. So the contrast enema, you had the impression it was the most common scenario, short segment, a rectal sigmoid. So you start the dissection. And as you start, you suddenly realize that you're either dealing with a long segment or with a total colonic aganglionosis. So throughout my career, I have learned that we are not taught to stop surgery. And sometimes stopping surgery is the best option for the patient. Why am I saying that? The worst case scenario that could happen to you is that you remove the entire colon and then you later find that you had ganglion cells. That is something, thankfully, it has never happened to me, but I think if it has happened to me, it would be very difficult to accept that I imposed a change in the life of a child that it's now irreversible. So that's the reason why I'm saying it is better to stop surgery than to complete an incorrect surgery. So once you realize that it's not what you were expecting, it's time to pause and think. I would recommend do the anastomosis wherever you are, you do your ileostomy, and then wait for permanent sessions. Don't remove, especially if you have a pathologist that don't have experience in doing intraoperative biopsies. In the third scenario, again, you did not suspect total colonic aganglionosis. This was an intraoperative finding, but you are in a center with very good experience in diagnosed Hirschsprung. You have a large number of cases. Your pathologist is very familiar. Then, and you don't have, and the pathologists don't have any doubt of the diagnosis. And that's a conversation that you could have with the pathologist. Are you confident with our specimens? Or should we wait and look in the permanent section? And if you are 100% confident, there is no doubt this is total colonic aganglionosis, then you can do the colectomy, the ileoanal anastomosis, and a protective ileostomy. And the question that comes next is, when are we gonna close this ileostomy? So in the first scenario, the question is, when are we gonna do the total colectomy and ileoanal anastomosis? And for the second scenario, when we're gonna the second scenario was the one that we just did leveling biopsy. So again, when we are gonna do the colectomy, ileoanal anastomosis. And the third scenario, when we're just gonna close the ileostomy. So our recommendation for closing an ileostomy or finalizing the ileoanal pull-through in a patient with total colonic aganglionosis is when the patient is toilet trained for urine and when the patient accepts rectal irrigation. So the longer the segment of aganglionosis, the higher the chance of enterocolitis. So in a patient with total colonic aganglionosis, you can expect that this patient will suffer from enterocolitis. I know the term is not even correct. We can say enteritis because there's no colon anymore. But it is true that the patient will need irrigations. So we don't want a patient that is fighting you, especially because you will have a fresh anastomosis. You need the patient relaxed that lets you do it. So we always tell families that they have to prove to us in the office that the child can accept rectal irrigation. And if the child is fighting, if the parents are having to force the child in the table, it's not time to do the pull-through because post-operatively, they will need rectal irrigation. And why we don't close this ileostomy sooner? Number one, the ileostomy in the beginning, of course, especially the parents didn't expect their child to be born with a condition. It's a shock for them that their child will have a stoma. But once the child has the stoma, if you have done a good ileostomy, the child is growing, the child is happy, normal life. Now, if you do an ileoanal anastomosis in a baby that is not toilet trained yet, this child will have multiple uncontrolled bowel movements and a very severe diaper rash that it's very difficult to manage. Why is that? The small bowel has a fast motility. That's normal for the small bowel. And when we don't have bowel control, we will be passing this constantly into the diaper. Now, once we have bowel control, and that's something that develops with age, most kids, it does not develop before 3 years of age, then the child knows that when they feel something, they run to the toilet. The first few days, there will be several bowel movements, but then it becomes something manageable. And when you do the ileoanal anastomosis after the child is already toilet trained, you avoid the diaper rash. The diaper rash is extremely painful for children. So I think I explained why we don't recommend an ileoanal pull-through in a baby, because babies do not have bowel control. Even if you do a perfect surgery, if you preserve the anal canal, the baby will suffer from severe diaper rash that is very hard to manage. The other problem that we frequently find in patients with total colonic aganglionosis, because they need ileostomy, is that ileostomies have a tendency to prolapse. And the question is, why do ileostomies prolapse and how we can avoid it? So I'm going to show you an image of the colon so you can understand why colostomies may have a tendency to prolapse or not. We have to remember what portions of the bowel are naturally fixed to the abdominal wall. So if you open right transverse colostomy, this proximal stoma will have a tendency to prolapse because it was created in a mobile portion. The transverse colon is mobile, but the mucus fistula, since it's close to the splenic flexure, will not prolapse because it's fixed to the abdominal wall. Now, if you open a right transverse colostomy, sorry, that one is a left and this one is a right. Transverse colostomy, this one will not prolapse because it's close to the hepatic flexure, and this one will have a tendency to prolapse, the mucus fistula. And in anorectal malformation that we recommend a descending colostomy, the proximal stoma will not prolapse because we recommend making it close to the attachments, but the mucus fistula is the one that will have a tendency to prolapse because the sigmoid is mobile. And that's why we recommend the mucus fistula to be made tiny, because that will also avoid the prolapse. So the question is, the ileum is completely mobile. So how can we avoid prolapse? And the way we do it is, once we select our segment, we fix approximately 7 centimeters to the abdominal wall in an attempt to avoid that stoma from prolapsing. In an ileostomy, you also want to brook the stoma really well. You want to have about 2 centimeters above the skin, and you want to do it in an area that the stoma bag will be able to be adapted without having the bag fall. So we try to stay away from the ribs. We try to stay away from the iliac crest because those are the areas that are constantly moving. So you want to do a flat area where the bag can be adapted. You have to think that you are making a stoma that will be in place for at least 3 years. So dedicate your work in making a good stoma, because that's what's gonna mean quality of life for this patient and this family. Now, when a prolapse happens, how do we fix the prolapse? So we use those packing gauze filled with betadine, and as we are introducing into the stoma, we are reducing the prolapse. So we slowly introduce it, and then we're gonna palpate where this packing gauze, you feel like a sausage inside the abdomen. What's the direction that that ileum is moving? So let's suppose you palpate and you feel it's here. You don't have to touch the stoma itself, because in this case, the stoma looks very nice. You can see that the mom is able to adapt the bag. So if you palpate around this area, then we're gonna make an incision on this area in the skin, subcutaneous tissues, aponeurosis. You're gonna confirm that that's your ileostomy, that's the bowel proximal to the stoma. And then you're gonna start closing the aponeurosis, getting a bite of that stoma. So you're fixing that stoma to the abdominal wall. So in that example, we're palpating that sausage of packing gauze around here. So we're gonna make an incision, open the aponeurosis, and then as we close, we're gonna take a bite of that stoma. So that's how we fix those prolapse. We do our best in any of our patients to never remove bowel. So we try to reduce and fix to the abdominal wall. Now, problems of the ileostomy, patients have a tendency to dehydrate, so it's very important to tell families to keep patients hydrated, especially during hot days, and they can lose a lot of salt from the ostomy. So, and there is the glucose salt pump that is very important for growing. So what we do every time we follow our patients, and in the beginning we follow them every month, and then every 3 months, then every 6 months, then every year, we check for urinary sodium. So we tell the mom before coming to consultation, if it's a boy or a girl, put a cotton ball near the genitalia so we can catch urine. And then we're gonna ask the laboratory for the urinary sodium. If you find it lower than 20, you have to start oral sodium supplementation. So here it's we have to ask the pharmacy to make it. It's 4 mg per ml, and we start with 1 mg per kilo every 12 hours. And then we redose in another month. If it's still lower, then you double. You go to 2 mg per kilo every 12 hours. But usually once you start replacement, you see that the urinary sodium becomes normalized and the child starts to grow. So we're a very important topic, and I know Dr. Peña will talk about that, and Dr. De La Torre will also emphasize, is that for all patients with Hirschsprung, the anal canal is their chance, is their possibility of bowel control. But in a patient with total colonic aganglionosis, this is even more vital, because if you damage the anal canal during the operation, this patient will need a permanent stoma. The question is why? Well, because what's the treatment that we offer for patients that suffer from fecal incontinence? The treatment is enemas, but we can only do enemas in the colon because the colon does not absorb nutrients and the colon has solid stool. We cannot do enemas to keep the patient clean in the small bowel. The small bowel absorbs nutrients. The small bowel has liquid stool. So if the patient suffers from fecal incontinence because of a damaged anal canal, a patient with total colonic aganglionosis needs a permanent stoma. There is no bowel management for patients with damaged anal canal and lack of colon. So this is a very important message. This is an example of a patient with total colonic aganglionosis that came to us, and this was the worst diaper rash that we have seen in our life. The patient had even lymph nodes, and the patient could not sit because of pain. So the family came to us thinking that they could get good creams and bowel management with enemas, and we had to tell the truth that for these cases, there is no such thing. There's no cream on earth that will take care of this diaper rash, and there is no bowel management. This patient needs an ileostomy for life. So let's go to a case scenario. Let's suppose you receive an email of an anxious mother saying that her 2-month-old daughter received a diagnosis of total colonic aganglionosis. She underwent an ileostomy that it was made in her umbilicus, and the surgeon is planning a pull-through in the next 6 months. She wants to know your opinion about the case. So before giving your opinion, it's very important to gather all the information. So you want to know, is this child eating and growing well? And we want to know, do we have a recent urinary sodium? You also want to know, does this child have the colon inside or the colectomy has already been done? Why? Because even defunctionalized colon can still have enterocolitis, and sometimes that's a cause of bacteria proliferation, and that's why the patient has higher outputs. So any signs of enterocolitis? Does the family know how to do rectal irrigation if needed? Based on this, you will see how well this patient has been managed. So this child was not growing well. Her ostomy was horrible, and the family was suffering with the care. She was never taught about rectal irrigations. The colon was still inside, and she has never been dosed for urinary sodium. So the family came, and this was the stoma. And this is a lovely mother that took amazing care, but it was impossible to manage this stoma. So the idea of creating stomas in the umbilicus is those great ideas that unfortunately don't work. The idea was we're gonna use an area that already has a scar, so when we close it, it will look like a nice umbilicus. Unfortunately, that does not work. At least all the stomas that I have seen in the umbilicus, the cosmetic result, once it's closed, it's not good. And for an ileostomy, it's extremely hard to keep this area because this area is deep. So the intestinal content is constantly there, irritating. So I told this mom, I said, we cannot keep this child suffering with this stoma for the next at least 3 years of her life. So we have to revise her stoma. So we revised her stoma, and here you can see the cosmetic results of the umbilicus. Still is not good, but now she has a beautiful stoma, and you can see the difference in the skin around the stoma from here, even after 2 months, how the umbilicus was still suffering from all the irritation. So the ileostomy was revised. The mother was taught how to do rectal irrigation. She was growing and eating well now without any complications. So the question is, when would you recommend the ileoanal pull-through? And again, we recommend when the child is toilet trained for urine and it's accepting rectal irrigations. So here you can see we start the patient in prone position. We place the Lone Star, we put it deeper to protect the anal canal, and we start our dissection around 1 to 2 centimeters from the pectinate zone to fully protect the anal canal. So here you can see all the anal canal is here protected, and you can see this area also is preserved to make sure the anal canal is 100% preserved. So the patient underwent colectomy and the ileoanal pull-through. So here you can see the ileum, and we're gonna anastomose this area to this area for the pull-through. And here's the final anastomosis, and you can see that the anal canal is completely preserved. So this patient is now 10 years old. She has 4 to 6 voluntary bowel movements a day. And I just want to show what the radiograph of a patient with total colonic aganglionosis that had an ileoanal pull-through looks like, because if you look at the radiograph, it almost seems as the patient still has a colon, because the small bowel takes up on the function to retain some stool, something that the small bowel was not made for. And that's why it dilates, and it's this abnormal imaging that we see in all patients with total colonic aganglionosis in the long term. When we do an X-ray, almost all radiologists would think the patient still has a colon, but this is just the small bowel. And this is another case. This is a 3-day-old male patient presented to the hospital with bilious emesis and abdominal distension. This is the abdominal radiograph. and this is the contrast enema. In the contrast enema, you don't see a characteristic image, but this was suspected for total colonic aganglionosis, underwent leveling biopsies and ileostomy, and this patient is currently waiting to meet criteria for ileoanal pull-through. We don't pressure on our patients. I now have a 6-year-old with trisomy 21. He's doing fantastic with his ileostomy. He's just now toilet training for urine, and the mother is not on a rush to do the ileoanal, and we don't pressure them. It's whenever they accept rectal irrigations and are fully trained for urine. Now talking about patches and pouches, and it's again the same concept as the stoma in the umbilicus, is when ideas and desires are good. So the ideas for those surgeries, or what the surgeon desired, was that this would absorb water, form solid stool, and decrease the number of bowel movements. So the idea behind creating pouches is very good. But the reality is, what it happens is they produce fecal stasis, bacterial proliferation, inflammation, and secretory diarrhea. So they do not work, and that's why we recommend direct ileoanal anastomosis. You have to remember that in patients with Hirschsprung, when you provoke stasis, when you retain stool, it generates enterocolitis. It's not something that we fully understand, because patients with idiopathic constipation, they have a lot of stasis and they don't have enterocolitis. But patients with Hirschsprung, they do. And that's why pouches don't work for patients with total colonic aganglionosis, because we generate more infection on them. And yesterday there was a question about using the appendix to diagnose total colonic aganglionosis. So that's something we were very interested in, our group decided to study. Is the appendix good to diagnose total colonic aganglionosis? So we did study 112 appendices. 9 were patients with total colonic aganglionosis. In those 9 patients, there were no ganglion cells in the appendix. We had 5 patients with Hirschsprung disease, like a rectosigmoid Hirschsprung disease. Those patients had ganglion cells in the appendix. And all the rest were patients either with malrotation that had the appendix removed early in life during the first month, patients that underwent a Malone procedure for anorectal malformation, Hirschsprung, and in all of them, there were ganglion cells. So with our wonderful pathologists, yes, the appendix can diagnose. But if there is one suggestion, do not remove the entire appendix. Just remove the tip of the appendix, because that should be enough if you have a good pathologist. Because in the event that I hope it's not going to happen to you, that the anal canal is damaged, the appendix is very good for a future Malone. So do not remove unless extremely necessarily. And if you don't know if it's total colonic aganglionosis or not, at this point, try to just remove the tip and wait for the diagnosis. But again, remember, you need very good experienced pathologists. And the appendix should never be used as the first resource to diagnose. Remember, the first resource is always the rectum. We must have the rectum, because I have seen, and when I say this is because I have seen, sending the tip of the appendix and say, oh, it's a case of Hirschsprung. No, you need to have the rectum to confirm that it's Hirschsprung. You may send the tip of the appendix if you are suspecting total colonic aganglionosis. So that would be our message. But again, be very careful. You're sending a small piece of tissue that will represent a huge decision. So don't take this lightly. Take this seriously, caution, and slowly, because you really need to have confirmed diagnosis before you commit yourself to doing a colectomy, which is irreversible in a child. And with that, I'll finish my talk, and I'm happy to answer any questions. Thank you very much. Let me see if there are questions. When you do an ileostomy in a Hirschsprung patient, do you recommend one stoma or two stomas? I already mentioned that. I always recommend for colorectal patients 2 stomas. This is a patient that will have an ileostomy for a long time, especially if you have the colon, the entire colon. It's better if you can have access to the mucus fistula to flush and do rectal irrigations. Any other questions, Dr. De La Torre?
Yeah, you already responded about the appendectomy to do the diagnosis of total colonic. After SUAVE, we observe some opening in the perineal area of children. What is that? Is a fistula? It's a question.
I am not sure I understand the question.
Me neither. Can you explain how do you fix 7 centimeters of the ileum when you create the ileostomy?
Yes, so you have the stoma here, and then the 7 proximal centimeters from your stoma, you're just gonna suture to the abdominal wall. You can suture, I usually use Vicryl, so you're just gonna suture with interrupted stitches to the abdominal wall.
There another one. It is I don't understand the question. What are your expert view on hanging bowel technique?
I don't know what that is.
Okay.
Do you do the entire colectomy transanally? Absolutely not. I don't know if the bowel is normally fixed. I don't know that anyone can do an entire colectomy transanally. If you have a patient with 2 high perineal fistulas after surgery, do you consider that a lost anal canal? I don't know. I'm assuming it's a fistula from the procedure. And is that a loss of the anal canal? Not necessarily. You may still have a preserved anal canal and a fistula, but it's impossible for me to comment without examining the patient, seeing the images, understanding the anatomy. Do you recycle the ileofluids into the mucous fistula? No. This is a patient with total colonic aganglionosis. This colon does not work, so you should not be trying to inject fluid on it. We only do rectal irrigations if we're trying to clean that colon.
Andrea, when you take a biopsy from the tip of the appendix, are you not changing a clean procedure to a dirty procedure?
So we are doing multiple colonic biopsies. This is not a clean procedure.
Okay.
Is the reason for toilet training for urine to avoid diaper rash too? 100%. That's the reason. The patient has to understand how to go to the toilet and make it to the toilet. That's what avoids diaper rash and obviously preservation of the anal canal.
What other options, surgical options, do you offer to patients with total colonic aganglionosis on stomach?
I don't offer other options. I truly believe this is the best option to have an ileostomy until toilet trained. And once the patient is toilet trained and accepts rectal irrigation, I do an ileoanal pull-through. So that's what my patients get it. And at what age do you do the ileoanal pull-through? not before 3 years of age. I have done in 4 years old. I have done in 6 years old. I have done in 8 years old, but never before 3 years of age. The conditions are patient is toilet trained for urine and accepts rectal irrigation. I will only do the pull through when the patient meets those two criteria.
Very good. Okay, thank you very much. If there are more questions, Dr. Bishop can type in the chat.
Perfect.
So we can move forward with the next conference.
That it's going to be given by Dr. Luis de la Torre about long segment aganglionosis.
Thank you. Okay, so first of all, I want to share with you some important concepts about what is long segment aganglionosis. This is the name that you can hear everywhere. But what is a real long segment aganglionosis? The goal of this conference is trying to explain you how to understand long segment aganglionosis. Number one, remember, Hirschsprung is always a rectal problem. So all the patients with Hirschsprung have aganglionosis in the rectum. Concept number two, also all patients with Hirschsprung, they have rectal and anal canal disease. In other words, Hirschsprung is present in the rectum and in the anal canal, and I will explain this situation. So the question is, how many types of Hirschsprung exist? How many types of Hirschsprung are there? So if you read the literature, you can find publications talking about short segment, long segment, total Hirschsprung, near total Hirschsprung, classic Hirschsprung, universal Hirschsprung, typical Hirschsprung, too short Hirschsprung, ultra short Hirschsprung, or ultra short Hirschsprung. So everybody is trying to express the idea how the length of the affected bowel in every patient. So there is a paper from 1957 published by Bill, Crichton, and Stevenson, and they proposed the selection of infants and children for the surgical treatment of Hirschsprung. So what they found is a group of patients just with aganglionosis in the rectum and the distal sigmoid. This is the original image. They found another group of patients where the aganglionosis affects also the left colon, the splenic flexure, and we can say part of the distal transverse. And a group of patients with total colonic aganglionosis affecting the entire colon and probably some centimeters of the ileum. So they divide the group of patients in three groups. The patients with Hirschsprung, patients with long segment aganglionosis, and patients with total colonic aganglionosis. And I think even after many publications, and I want to show you a new survey about this topic, I think this is the most accurate classification if you want to classify. But remember, as in biology, Hirschsprung is a spectrum. So if the patient has aganglionosis in the rectum, and let's say up to here is going to be long, or is going to be short, or is going to be classic. They report 70% in this group, 25% in this group, 5%, which is more or less the same nowadays. Now, I want to show you this publication from last year. This was a survey from the American Pediatric Surgical Association about the outcomes and evidence-based practice in patients with long segment. So, first, in 22 papers, you can see the blue line. They call long segment when it was the rectum, the sigmoid, and all the colon except the distal portion, the proximal portion of the colon. This is a long segment. Proximal to the splenic flexure, three papers, so this portion. And a specific anatomic location, just 8, talking about long segment papers that were published under the title of long segment. So, as you can see, it's a mess. Then, the management of these patients. Most of the patients with short segment were in this percent in all publications. Long segment, total colonic, and small intestinal aganglionosis, which is unfortunately rare, were the less population. So we are going to talk, already Andrea talked about this group, and I'm going to talk about this group of patients. We already know what to do in patients when the rectum and the sigmoid is aganglionic. And probably, I'm almost sure that most of you are ready to do a total colonic aganglionosis after Andrea's conference. In the same paper, it's very interesting. When they finish this publication, this is the recommended Hirschsprung disease nomenclature proposed by the American Pediatric Surgical Association last year. Where are we going to call ultra short segment? We don't know, because it's not clear definition, and the use of this term should be abandoned. So, in conclusion, the ultra short segment, based on the recommendation of these expert groups of the American Pediatric Surgical Association, ultra short segment should be abandoned. Short segment, aganglionosis up to the sigmoid, colon, descending, colon junction is what they propose. Long segment, when the aganglionosis is from the sigmoid, colon descending, which is the left colon, up to the cecum. Total colonic, when you have the entire colon and 5 centimeters of the terminal ileum. A small intestinal Hirschsprung, when you have aganglionosis extending beyond the terminal ileum, more than 5 centimeters. Total intestinal Hirschsprung, more than 20 centimeters of ganglionated intestine beyond the ligament of Treitz. If you want to express the anatomic location, will be much, much better. Again, this is the most common form of Hirschsprung. This, for me, this should be long segment and total colonic. What is important in every patient, it doesn't matter if it is short, ultra short, long, super long, we need to obtain normal colon. That means good pathology, ganglion cells, no hypertrophic nerves, and good irrigation. Then how to pass the bowel into the pelvis, which is the blind zone in this anatomy, in this operation, and a good anastomosis. Not too low, not too high, and very delicate and adequate performed. If you have a patient with this disproportion dilation proximal to the ganglionosis, most probably you need to resect this segment because this segment is not going to have good motility. This is a very old illustrations about the anatomy of the blood supply of the colon. So as you can see, the left colon is irrigated just by this portion, the EMS right here, and the right colon and the transverse colon by the SMA. So these two big branches or main branches or arteries have a communication right here. This is very important when we talk about long segment. When you are doing a patient with a short segment or rectosigmoid aganglionosis, the blood supply usually is not a problem. When you have a total colonic aganglionosis, the blood supply is not going to be a big problem. The problem is when you have a long segment affecting the splenic flexure, probably 1/3 of the transverse or the right side of the transverse or half of the ascending colon. So this artery is very important. So in my opinion and my recommendation, if you have a patient with long segment, and long segment means patient without short, which is colon and sigmoid, and patient without total colonic, you need to take care of this area. So doing a left transverse colostomy is risky because you can damage the blood supply in the future or for the future pull-through. So mobilization of the colon is very important in all patients with long segment. I recommend to do omentectomy. We have patients with long segment with many problems because the surgeons, they did not remove the omentum, and then the omentum is in the pelvis, creating a lot of problems. When you have the right colon very, very dilated is a big problem. So in these cases, the decisions are difficult, are not very easy. Long segment has the most common complications. Is the most difficult type of Hirschsprung to demonstrate the transition zone with a contrast enema. And it's one recommendation, try to avoid primary pull-throughs in these patients because usually these patients have many problems. So you can do the pull-through and leave a protective enterostomy, colostomy, or ideally an ileostomy for 3 to 6 weeks. The surgical complications in patients with this type of Hirschsprung are residual aganglionosis, fecal incontinence, when you use reservoir pouchitis, dehiscence of the anastomosis could be partial or total dehiscence, stenosis, coloanal stenosis, fistulas, abscess, rectal stenosis, atresia of the rectum, etc., etc., etc. All of them are preventable. So we need to take care of these patients very, very well. This is a contrast enema of a patient with long segment. What we found in this patient was aganglionic the rectum, aganglionic the sigmoid, aganglionic the left colon, and this portion of the transverse. So you cannot see exactly where was the transition zone. So it's difficult to define the transition zone when you have a patient with long segment. So again, long segment aganglionosis, remember, take care of this blood supply. One option is to do an ileostomy you can take your biopsies and define exactly where is the area of the histological transition zone. We usually always do an ileostomy. This is the functional stoma and the mucous fistula. Okay, now you can do a straight pull through when you have to mobilize the right colon, would be this the hepatic flexure, this area, or the right half right of the transverse colon. But if you mobilize this portion over the ileum, probably you are going to produce a mechanical obstruction in the distal ileum. So the lawyers is a procedure where you need to detach all the right colon and all the attachments, obviously from the hepatic flexure, and you need to do an omentectomy, and then you need to switch the right colon in this direction and place here in the rectum. And now you will have the ileocecal valve localized in the upper right corner. This is a very useful technique in patients with long segment. Sometimes the blood supply does not allow to do this operation. So another option, this is what happened when you try to do a straight pull through. If you place the colon over the ileum, this ileum is going to have obstruction. That's why the lawyers is a good technique for this patient. Another option, if you are looking this diagram, you can imagine now what can you do, right? If the colon is going to be over this bowel, then you can do a mesenteric defect, avoid the obstruction, and then you can pass the colon behind the mesenteric, transmesenteric. And this technique was described by Turnbull. This is something that we do in this patient. I prefer usually to do this if the mesentery allows, or the lawyers, depending on the blood supply. This is another diagram from another series. This was published by Sileri using the same technique, the mesenteric defect, so you can pass the right colon using this technique. I think that the long segment is a real urgent situation, because usually this patient, they do not respond to rectal enemas. And when you do a contrast enema, usually you cannot identify the transition zone. So in these patients, if you are going to take the patient to the OR, you need to keep in mind what are you going to do in the future, right? If you are going to do an stoma first and then a pull through, or you want to do the pull through like a two-stage pull through and then leave a stoma for to protect the anastomosis. So this is a completely different entity, a completely different problem compared with the all we talked yesterday and compared with the total colonic aganglionosis. And this diagram is going to illustrate very clear and summarize what I said. If you have a patient with short segment, you can do transanal, you can do open, you can do laparoscopic assisted, you can do whatever you want, because this, unfortunately, this is the most common, is suitable for any type of surgery. When you need to detach all the attachments from the left colon and the splenic flexure, then it's a different operation completely. Imagine this case. So you have all these aganglionic, you need to detach all this. In this diagram, we are not showing a huge dilation and significant dilation of the right transverse colon, but usually is what you are going to find. And sometimes is super dilated, and then to mobilize this big, gigantic colon through megacolon in this very narrow rectum is challenging. That's why my suggestion, because these cases are not frequent, you need to try first an ileostomy, and then you can do the pull-through, and then you can close the ileostomy. Is my suggestion, like a safe plan for patients with long segment Hirschsprung. Thank you. We are on time. Let's see if we have some questions here.
We do have a few questions. What do you do with the left splenic flexure pull through? Does the middle colic always have to be sacrificed?
Yeah, it's what I already explained. If you need to, you have a patient with aganglionosis of the left colon affecting the splenic flexure, the most important arcade is the communication between the superior and the inferior mesenteric artery. So you need to preserve this blood supply, and you can do a straight if you are not going to produce any blockage in the small bowel, or if not, you can do the lawyers, or you can do transmesenteric. On what situation do you need to make protective colostomy or ileostomy in these patients? The colostomy or ileostomy to protect an anastomosis is always a safe procedure. If you are doing a challenging pull-through where the visualization of the bowel shows that it's kind of ischemic, you are not super happy with the anastomosis, I strongly recommend to leave a protective enterostomy. If you are doing a beautiful pull-through, good irrigation, there is no any chances to have any leakage, and the bowel reach the rectum very, very nice to create a neorectum, you can avoid another stoma. Is surgeon preference, but always remember, a colostomy or ileostomy is a safe procedure. So don't be afraid to leave an ileostomy after a pull-through if you are not happy with the operation. Okay, think about if you are doing the pull-through in your own son or in your own daughter, and then you will take the best decision in these cases. What is your experience with segmental Hirschsprung cases? We don't have, unfortunately, we don't have the opportunity to see yet this type of aganglionosis. Yesterday, it was mentioned that the contrast enema only raised in 68% of the cases to the transition zone in the surgical specimen. Yeah, this is a new publication, Diego. When you read papers about contrast enemas in patients with Hirschsprung, you need to think the circumstances when the contrast enema was performed. Let me tell you, usually when a newborn came to the hospital with intestinal obstruction and the surgeon decided, the team decided to do a contrast enema, The patient usually has colitis. Usually this patient never had an irrigation. Usually the radiologists, they don't have experience doing contrast enema. And usually the contrast enema is not indicated for Hirschsprung. Usually is indicated looking for malrotation. So these studies have a bias. So to me, is not accurate, this percent. So you need to understand in the circumstances where the contrast enema was performed in these studies. Endorectal pull-through, yes, you can do endorectal pull-through. You mean Suave, you can do Duhamel, you can do Swenson in short and long segment aganglionosis. That doesn't change. We explained this yesterday. Okay, I'm going to answer on the chat the remaining questions. Now, Dr. Alberto Peña is going to talk to you about the anal canal in patient with Hirschsprung. Alberto, good morning. Thank you very much. You are muted. Thank you.
Good morning. Good morning, Dr. De La Torre. Good morning, everybody. It's my pleasure to be back to talk about the anal canal in Hirschsprung disease. This is with the purpose of emphasize the importance of the preservation of anal canal. Let me say something first, very, very important. Patients with Hirschsprung disease are born with all the necessary elements to have bowel control. Unfortunately, many patients that have been operated for Hirschsprung disease are fecally incontinent. And that most of those cases is a result of a poor surgical technique and very frequently means damage to the anal canal. And that's why we put so much emphasis in the preservation of the anal canal. A patient that is subjected to operation for Hirschsprung disease, a technically correct operation for Hirschsprung disease, may have some functional disturbances because as we mentioned yesterday, we removed the natural reservoir of stool. And as a consequence, we are connecting a colon that is constantly moving to the anal canal, and the patient has a tendency to have frequent bowel movements. But that doesn't mean that it's incontinent, because if we preserve the anal canal in the sphincter, the patient will be continent with frequent bowel movements. Now that problem may interfere a little bit with toilet training. In other words, it may be a little bit more difficult to toilet train a child after an operation for Hirschsprung disease. But certainly there is no justification for fecal incontinence. So that's why we give so much emphasis to the problem of the preservation of the anal canal. The anal canal is, I'm sure Dr. De La Torre and has repeated this to you during this course, and you will just repeat it again. The anal canal is that part of the anus that goes from the pectinate line all the way down to the skin. This is the anal canal, and has the characteristic is that it's one of the most sensitive portions of our body, which allows us to recognize the difference between liquid, solid, and gas. In addition, the anal canal is, as you know, surrounded by the voluntary sphincter mechanism. So sometimes the damage that surgeons provoke to the anal canal include also the damage to the sphincter mechanism, and then the patient is going to be completely fecally incontinent. So let me just, I know that most of you know a lot about this, but let me just emphasize a few aspects about bowel control. Bowel control depends on sensitivity, sphincter, and rectosigmoid motility. Now, through the years, through the centuries, I would say, we usually simple-minded surgeons have been focusing our attention in the sphincter. We think that bowel control depends 100% on sphincter mechanism. That's wrong. Bowel control depends on the number one, sensitivity, as important or more important than the sphincter. Then the voluntary sphincter, of course, is important. And third, something that people usually don't talk about is the rectosigmoid motility. So the sensitive, as we are talking here this morning, we feel that something is moving toward our anal canal, and we are able to say if that's gas, liquid, or solid. And depending on our surrounding circumstances, we decide to hold it, and we send an order from our brain to the voluntary sphincter to contract and avoid the passing of stool or gas or whatever. That's the usual mechanism. The moment we are ready to go to the toilet, the person goes to the toilet, sits there, and waits a little bit for another wave of peristalsis of the rectosigmoid, and then the rectosigmoid empties. Under normal circumstances, empties completely. So the wonderful thing about the reservoir, the rectosigmoid, is that for 24 hours or sometimes more time, it simply doesn't move. It just catches the stool, and we continue going on with our social life. But when the rectosigmoid decides to move, it empties completely, and that's the function of the reservoir cannot be overemphasized. The importance of that reservoir is extremely important for our social life. So you can imagine if we remove the rectosigmoid, then we are connecting, as I already said, a colon, descending colon or transverse colon or ascending colon that is constantly moving. It's not a reservoir. And we are connecting that to the anal canal, and therefore the patient will experience the desire to pass the stool very, very often. So if we have no sensation, if we have no anal canal, the stool will come out without us knowing. And doesn't matter if you have or you don't have a sphincter, the stool will come out. You will realize that the stool is coming out once it's already out. And that's the importance of the sensitivity provided by the anal canal. But remember, keep these three elements in mind when you talk about bowel control. Examples to emphasize the importance of rectosigmoid motility. So there are patients, you have seen patients that have normal anal canal, no anorectal malformation, normal sacrum, and severe constipation. Constipation for us means a severe disturbance in colonic motility, and maybe very mild that you pediatricians take care of with a little bit of prune juice, to extremely severe and overlapping with what is called intestinal pseudo-obstruction, and patients die from that. The bowel simply doesn't move. So severe constipation means severe dysmotility of the rectosigmoid. And those patients have normal anal canal, normal sphincter, and yet they soil the underwear. They go to the clinic, to our clinic, soiling the underwear constantly, 24 hours. They have what is called overflow pseudo-incontinence. That's an example of the importance of the very peculiar motility of the rectosigmoid and the function as a reservoir. Another example is when you have an adult patient that underwent a total colectomy for ulcerative colitis or other reasons, and then the small bowel, the terminal ileum, is connected to the anal canal. Under the best circumstances, the operation performed by a master surgeon. Anyway, the patient has, at the beginning, after the operation, has a little problem holding the stool, and sometimes have nocturnal fecal incontinence because the peristalsis of the small bowel is constant, and it's sometimes severe contractions of the small bowel, and the patient is not, even when you have anal canal, the patients may have episodes of fecal incontinence. So as I already mentioned, the sensitivity of the anal canal provides discrimination between gas, liquid, and solid, and the sphincter. People talk about the internal sphincter. Yesterday, I mentioned that I don't know exactly what's the function of the internal sphincter. Some people says, I don't know why, that is responsible for bowel control. I don't believe that. So the internal sphincter is a controversial, from my point of view, its function for bowel control is controversial. But the external voluntary sphincter, skeletal muscle, is certainly very important. Here you see in this beautiful picture of a real anatomy of a male cadaver. This is the bladder. This is the posterior urethra. This is the prostate right here. This is the spongiosum tissue of the vulvar urethra. This is the sacrum. This is the coccyx. And look at the way the sphincter, this is voluntary muscle. This is voluntary muscle. It runs from this point in continuum all the way down to the skin. There is no separation. There is nothing that looks like a pubis rectalis. It's a continuum of muscle that goes all the way down and extends in this direction. So this is like a funnel-like muscle surrounding the rectum. That's what I call the real anatomy. All the diagrams that you have seen in books, that's imaginary anatomy. But the real anatomy is seen in this particular beautiful picture that I found in a textbook of anatomy by British professors who managed to divide the cadaver of a male right in the middle. So, but it's very important for people to know that this part of the rectum, this is the lumen of the rectum, from the pubis to the coccyx, all this down under normal circumstances is closed. As we are talking this morning, that part of our rectum is closed. There may be a stool up here, but this is closed from here to here. And that's extremely important also to interpret contrast studies. When you put contrast material in the colon, the contrast stops right at the pubococcygeal line, because this is closed, because we have this muscle has a constant tone that keeps this closed. This opens only to expel gas or stool during defecation. And to confirm that, I want you to look at these MRI studies. These MRI studies help us a lot to understand better the way this works. This particular patient suffers from severe constipation. Look at the stool. This is the bladder, this is the pubis, this is the sacrum, the coccyx, and this is the posterior urethra. This is the penile urethra. And look at this, under normal circumstances, as I mentioned, from the pubococcygeal line to the skin, this is closed. This will only open during defecation. And again, look at this sphincter mechanism. Starts here, runs all the way down to the skin. There is no natural separation between ischiococcygis, pubococcygeus, puborectalis, all those structures that were the product of imagination of French anatomists, and they are used currently to torture medical students because there is no reason to learn that terminology. It would be much better to teach the medical students how the sphincter really looks like this. So now in this other MRI here, you see what happens when the patient is defecating. So the nowadays, and there are MRI studies, and the radiologists use a special gel in the rectum that can be visualized here to be seen in an MRI study, like a contrast enema. So here the patient is defecating, and you can see that the sphincter relaxes, and you can see contrast all the way down here. By the way, another very important issue about this recognizing and learning about this that I call real anatomy is the interpretation of distal colostograms. When you put contrast material in a distal stoma and you inject the contrast material down, the contrast material will always stop at the pubococcygeal line. And sometimes you can see the very dilated rectum, and then here you see a lot nothing or rather narrow rectum. Unexperienced radiologists may confuse this with an aganglionic segment, and that's not an aganglionic segment. When the narrow portion starts at the level of the pubococcygeal line all the way down, that is not a ganglionic segment. That is the normal effect of the sphincter mechanism. This is very important to recognize that. And also in anorectal malformations, when you inject contrast material in the distal stoma to determine the location of the fistula, the contrast material again will stop at the pubococcygeal line unless you apply hydrostatic pressure high enough to overcome the muscle, the tone of this muscle, and allow the contrast to come down and show the real location of the fistula. And that's why many misdiagnoses are made with a distal colostogram without enough high pressure, hydrostatic pressure. That's why we call that study a high pressure distal colostogram. Very important. Let's see this.
There's no way to do that. Okay. Okay.
Well, what happens when if we remove the anal canal? No, sorry, I cannot see. If we remove, hold on 1 second.
Let me
Because
see
we
if I
cannot-
can move the label from
Yeah.
here.
That's it. What happens when we resect a rectum but preserve the anal canal in a normal patient or a patient with Hirschsprung disease? That's what we're supposed to do in patients with Hirschsprung disease. Resection of the rectum with preservation of the anal canal, or we do that sometimes in adults with ulcerative colitis. So what happens in those patients is that they preserve bowel control with frequent bowel movements. I already mentioned that. Now, let's consider a patient with an anorectal malformation, normal sacrum, not tetracord, and is what we call benign malformation. We call benign malformations those that have potential for bowel control, such as perineal fistula, vestibular fistula, rectourethral bulbar fistula, anorectal malformation without a fistula. Those patients have potential for bowel control, provided the surgeon performs a technically correct operation. So what happens? Those patients have bowel control, provided they have solid stool, and they are probably incontinent with diarrhea. Remember that those patients have congenitally, they do not have anal canal. And yesterday, somebody asked me a very interesting question: why do they have bowel control? And my answer was, they do have bowel control, provided they have solid stool. And they may have some accidents, but they are usually incontinent with diarrhea. And let's consider a patient that has anorectal malformation, normal sacrum, not tetracord, benign malformation, but we remove the rectum. The patient has total fecal incontinence. That's the recommendation then is try to preserve the rectum as much as you can in patients with anorectal malformations, because the rectum represents the reservoir of the patient. If the patient has no anal canal, by definition, and we remove the rectum, you have guaranteed fecal incontinence, even if the patient was born with a good malformation. Patient with Hirschsprung disease, removal of the rectus sigmoid with preservation of the anal canal, that's the ideal operation. Patient will have bowel control. Sometimes they have, they may have frequent bowel movements, and some patients have constipation, but the constipation is not due to the anal canal. The constipation is consecutive to this motility disorder. Those patients with Hirschsprung disease have, by definition, a dysmotility disorder. Now we know that the Hirschsprung disease is not just ganglion cells or no ganglion cells. It's much more than that, because even when we remove the aganglionosis segment, we are not curing 100% patients with Hirschsprung disease, because some of them, we don't know why, suffer from constipation, some others suffer from frequent bowel movements, some others suffer from enterocolitis, which continues being a mystery for us. I mean, the origin of enterocolitis. So now, patient with Hirschsprung disease, we remove the entire colon, like total colonic aganglionosis, with preservation, a good technique, preservation of the anal canal. The patient will have bowel control with multiple liquid bowel movements. And that's why in total colonic aganglionosis, we recommend not to close the ileostomy until the patient is guaranteed, patient is urinary continent. Preservation of the anal canal, the patient will have bowel control with multiple liquid bowel movements. In the left side, here in the left side, you see a normal anus, normal anal canal. This is the pectinate line, and this is the anal canal from here to here, from here to here, from here to here. And this is a patient that underwent a technically deficient operation, and the surgeon resected the anal canal. So the surgeon connected bowel mucosa directly to the skin, and the patient is fecally incontinent. Another case, there's no pectinate line. This is colonic mucosa directly anastomosed to the skin, and as expected, the patient suffers from fecal incontinence. Another similar case. So this is very sad. So those who are listening to me, and particularly those who are professors of surgery, and more important, those who are the professors in charge of the training of pediatric surgeons. In other words, they are in charge of the training programs in pediatric surgery, must think very carefully about how many cases of Hirschsprung disease do you need in order to teach a young fellow or resident to do these operations correctly, in order to be able to certify that he is capable of doing these type of cases without producing injuries, unnecessary injuries to the patient. Remember that patients with Hirschsprung disease come to us and represent what I call the paradigm of pediatric surgery. It's a patient that we can cure completely with our own hands. And therefore, the future of the patient will depend on the technical surgical details. And remember, there are congenital malformations like diaphragmatic hernia, in which the surgical technique to repair the hernia itself is relatively simple, relatively easy to teach somebody. The real problem in diaphragmatic hernia, particularly those with hypoplasia, pulmonary hypoplasia and pulmonary hypertension, the real problem is the postoperative care. It's extremely sophisticated, requires the participation of all other specialized doctors in pediatric neonatal intensive care, cardiology, pulmonology, and extracorporeal oxygenation. So that's very complex. In our malformation, those that we deal with in colorectal surgery, like Hirschsprung disease and anorectal malformation, the future of the patient will depend on the little surgical details. And that's why we have to emphasize the importance of a meticulous training our fellows before certifying that they are capable of repairing malformations without damaging the patients. For that, we have to remember, even when it is painful, we have to count the number of cases that are born with Hirschsprung disease in a hospital, divided by the number of pediatric surgeons that are operating, and then you will find that in many cases, there are not enough cases to maintain acceptable level of expertise in the surgeons. And there are not enough cases sometimes to train well our fellows. And this is an inconvenient question that I keep asking, but I want to remind everybody. So with that, so Hirschsprung disease, regardless of the level of resection with damage of the anal canal, produces fecal incontinence. So I thank you very much for your attention, and I will be very happy to try to answer if there are any questions.
What is your experience doing myectomies, posterior myectomies, in patients with Hirschsprung or intestinal neuronal dysplasia?
So that I learned about those procedures, myectomies, at Boston Children's Hospital when I was a fellow. And I performed a couple of those procedures and then abandoned that. I believe that that operation is not indicated. I believe that is the source of many complications. And I believe that the basis, the theoretical basis to justify that operation are absolutely wrong. And neuronal intestinal dysplasia, I'm sorry to say that I don't believe, I don't know what is that. When the first articles of neuronal intestinal dysplasia appeared, I was very enthusiastic, and I thought that I will explain many of the functional disturbances that our patients with Hirschsprung disease have, even after our operation. But it turned out I read all the literature about that, and it's rather confusing. There is no topographic, there are no papers discussing the topography of that neuronal intestinal dysplasia. And I heard the opinion of many pathologists. Some pathologists don't believe in that. I made a special trip to meet Dr. Meyer Ruge, the person who started talking about that. And then, so I heard so many opinions that my conclusion is, as far as I'm concerned, that doesn't exist. And if it exists, I don't know what to do with that. But of course, Dr. De La Torre, I would like to hear his opinion, and also our pathologist in Colorado. He would be nice to ask him what he believes about that.
Does the partial damage of the anal canal has the same result of a complete damage of the anal canal?
I don't know about that. It makes sense. It's a matter of common sense to believe that if the damage is partial, then the incontinence is going to be relatively easy to manage without enemas. I'm talking about if the patient has diarrhea, try to avoid diarrhea. If the patient has constipation, try to take care of the constipation. And I'm assuming that would be relatively easier to treat, but I don't have experience. I cannot tell you. I don't have an answer for that question.
Yeah, and there's another question very similar. How much damage of the anal canal will produce fecal incontinence?
I don't know.
Yeah. Yeah, you already answered about the myectomy. There are many questions about myectomies. Dr. Peña, what is your opinion about hypoganglionosis?
I don't believe that I don't know what to do with that kind of, if somebody tells me that my patient has hypoganglionosis, I would not do anything. I would take care of him like depending on the symptoms, but I would not do an operation for hypoganglionosis. When I hear that, yesterday I heard our pathologist to discuss that, and I'm happy to, I was very happy to hear his concepts, but nobody told me, nobody has mentioned specifically how many ganglion cells per square millimeter a normal patient will have, and what's the number the distance between one ganglion cells and the other, and what is the definition of hypoganglionosis. But then let me tell you, I have seen many patients that come with that diagnosis, and with or without that diagnosis, the management is the same. I will not operate a patient based on that histologic diagnosis.
Thank you very much, Dr. Peña. So if there are more questions, Dr. Peña is going to answer in the chat. Thank you again, Alberto. Now we're going to talk about a very controversial concepts. I want to be very clear in this section. We're going to talk about constipation versus Hirschsprung disease. Why we need to talk about constipation and Hirschsprung disease? Because sometimes constipation is a problem that is not treated properly, and the patient continue having problems, social problems. The parents become very, very sick with anxiety, frustrated. The same thing happened with the GIs, with the surgeon that are dealing with this patient with constipation. And then suddenly, a miracle occurs and they decide this patient probably has Hirschsprung. You know, so because the constipation is not responding to the treatment, then the patient could have Hirschsprung. Okay, that's the idea of this conference. So for everyone, constipation is just something that happens in all humans. Some have more constipation, some have less constipation. And it's a common problem related to different diseases, to different entities. Constipations occur when bowel movement become less frequent. Voluntary or involuntary, you can have a bowel movement. If you are in an airplane and you don't want to have a bowel movement flying from Denver to New York or from Paris to the United States, whatever it is, you have the capacity to hold this bowel movement. The consequence is the retained stool is going to be dry because the mucosa of the rectum has the capacity to absorb water. The same thing happened with the sigmoid. These two big natural reservoirs. So the stool now is going to be difficult to pass because it's going to be dry, big, and hard. And then the accumulation of these feces characterize this problem. That's how we can understand constipation. So constipation occurs in patients with Hirschsprung, in patients with idiopathic constipation, in patients with anorectal malformation, in patients with hypothyroidism, in patients with many other problems. Now, Hirschsprung, you already know, I hope, is a congenital disease, and the lack of ganglion cells in the rectum characterizes this disease and produces an intestinal obstruction. This is the colon. A normal colon, a normal large bowel, has two very important segments for humans. This one, which is the rectum, and this one, which is the sigmoid. These two segments, the function of these two segments is to collect slowly the feces that move from the right side to the left side. So the motility of this area is faster than this one. Is the bladder of the poop. So if you don't have a bladder, you are going to pee every 15 minutes or every 5 minutes. The bladder is the natural reservoir for pee. The rectum and the sigmoid are the reservoirs for poop. Now, look, big difference. On the left side, if you compare the rectum and the sigmoid, compared with a normal large bowel, this one is going to have an enlarged and dilated rectosigmoid. On the right side of the screen, right here, the rectum is narrow. It's completely different from this one and this one. And then the proximal segment is going to be dilated. So you already know that this patient has idiopathic constipation or probably was born with an anorectal malformation, or something happened here because the patient now has a mega-rectosigmoid. This is usually the anatomy of the patient with functional constipation. And this is the anatomy of the patient with Hirschsprung. So two big difference in a contrast enema. How can you see this anatomy? Only with a contrast enema. So if you are dealing with a patient with constipation, you must have a contrast enema to define the anatomy of the rectum and the sigmoid. This diagram illustrates clearly why constipation is a problem for many physicians. Because if the patient's born with an anorectal malformation and has constipation, then if the patient does not have a good bowel management for constipation, the next step is this one. They are going to do a biopsy. And then if something happened, the patient is going to have Hirschsprung. And then you are going to publish patients with anorectal malformation and Hirschsprung, which is very, very, very rare. Same thing happened. If you have a patient with idiopathic constipation, then if you don't have good bowel management for constipation, then the patient is going to be submitted to a manometry, and the rectal manometry is going to say there is no anorectal, the reflex of the, when you dilate the rectum, the mega-rectum, the sphincter is not going to relax. So the consequence is that the patient has Hirschsprung. Or if you take a biopsy in a patient with idiopathic constipation, and the biopsy is performed very low, or the pathologists, they don't know how to deal with these biopsies, then the patient is going to have Hirschsprung in patients with idiopathic constipation. So, big difference. Hirschsprung always begins at birth. You have a patient that is happy for the first 6 months of life. And then when the patient start to have solid fruits and is constipated, this patient is not going to have Hirschsprung. If the patient has constipation and also is very sick with full smell diarrhea, abdominal distension, vomiting, enterocolitis. Constipation, for some reason, these patients, they don't have enterocolitis. If you are going to do the stimulation of the rectum in patients with Hirschsprung, most probably you are going to have an explosive bowel movement. In patients with idiopathic constipation, you are going to feel just a rock, a fecal impaction. Patients with Hirschsprung, they usually don't have soiling encopresis or pseudofecal incontinence. The stool in patient with Hirschsprung, for some reason, is not hard, dry, and big as in patients with idiopathic constipation. When you have a patient with Hirschsprung and you are doing irrigation, it's very rare to obtain big and dry balls of stool. Usually the stool is not in this with these characteristics. Enemas. The enemas in patients with Hirschsprung produce a lot of problems. The patient becomes sick with nausea, vomiting, abdominal pain. That's why we do not perform enemas in Hirschsprung. That's why we perform irrigations. We already said in the contrast enema, the rectum is the key. The rectum is the most important segment that you need to study in a contrast enema to differentiate between idiopathic constipation and patients with Hirschsprung. If the rectum is not dilated, most probably the patient is a patient with Hirschsprung, and for sure is not a patient with idiopathic constipation. Again, in a patient with constipation, constipation can begin at any age, newborns, infants, teenagers, adults, any patient can have constipation. But these patients, they don't have enterocolitis. We don't know why they don't, even when they can retain a lot of stool, they don't have this problem. They don't have explosive bowel movement. What they have usually is soiling, and the soiling is the consequence of fecal impaction. If the patient has a lot of constipation and he has a lot of stool in the rectum, some soft stool, natural soft stool, can pass through these rocks and produce this soiling. You can call this encopresis if you are physician or GI. Surgeons prefer to say pseudofecal incontinence, which is the same thing, just with a different name. Patients with constipation produce hard, dry, and big feces. Enemas are very useful in patients with idiopathic constipation in the bowel management. The contrast enema, again, is key to differentiate between Hirschsprung and constipation. Many years ago, when I was doing my fellowship and my first years in the colorectal service in the Instituto Nacional de Pediatría, I remember very clearly. The gastroenterologists, they manage all the patients with constipation. And then suddenly one patient was referred to us for a rectal biopsy because probably the patient has Hirschsprung. They said, I think the patient has Hirschsprung. So we took the patient to the OR. We obtained a good rectal biopsy, and then the pathologist report ganglion cells present in the submucosa, no hypertrophic nerves. So the biopsy was normal. Then the patient was in the limbo. The patient was, nobody wants to see this patient because surgeons, we said, no, it's not Hirschsprung, it's medical problem. At that point, the group of the GIs, they said, we don't have anything to do. We already did everything we know, and the patient is still having problems with constipation. What happens in patients with constipation is very simple. The accumulation of stool in the rectum for more than 24 hours usually is going to produce the big, hard, dry, big stool. Then painful bowel movements. In very young patients, the brain is very new and they learn very fast. If they have a painful, difficult, stress time during a bowel movement, these patients learn very fast. To have a bowel movement is not funny. To have a bowel movement is a very challenging situation in my life. Is what happened in most of the patients, in patients without neurological problems, in patients without autism, normal patients, neurologically normal patients. If you don't treat this pathological cycle, then the patient is going to have what we call fecal incontinence, because in reality, the patient is having involuntary bowel movements. Why? Because usually these patients receive a lot of a powder that is called polyethylene glycol. When you give polyethylene glycol in these patients, the possibility to produce liquid or very soft bowel movements is really high. In the treatment of constipation, we want to produce good bowel movements. No, we don't want to produce liquid bowel movement. We don't want to produce diarrhea. Usually, if the patient is constipated, is going to have hard, dry, and big stool balls. And then it's going to have fecal incontinence. If you want to call encopresis, that's fine. If you want to call soiling, it's fine. If you want to call this pseudo-fecal incontinence, it's fine. But in reality, the patient, when you don't have bowel control and the stool came out, you are fecal incontinent. I don't say it's going to be forever. It's a transitory fecal incontinence. The other big consequence is that the rectum is going to start to enlarge, to be bigger and bigger and bigger. These are the two most common complications in patients with constipation. This is a picture that expresses what I already said. This patient is on diapers. This patient has constipation, is taking polyethylene glycol for the last year. He is taking 3 cups of polyethylene glycol every single day. And mom is super happy because now the patient is expelling something from the anus. The patient is having bowel movements. But most of this is 99% is polyethylene glycol mixed with our internal juices from the liver, bile, pancreatic juices, and then into the colon. Is going to take the color of the feces, is going to smell like a poop, and looks like a poop. In these patients, when we obtain an X-ray, you are going to see big, hard balls of stool in the rectum, causing a blockage. But this soft stool is able to pass through this blockage. This is an example, an X-ray. One of the common errors in the treatment of constipation is nobody takes an X-ray of the abdomen or abdominal X-ray to evaluate the amount of stool that the patient has already. If this patient is seen for first time in your clinic because constipation, usually you are going to prescribe laxatives. And usually the most common is polyethylene glycol. And the patient is going to have bowel movements. But these pseudo or fake bowel movements are from the polyethylene glycol. This is another case, is a worst case. But I want to show you this because this is a patient already with complications. He has a huge mega-rectum sigmoid. Imagine that this is after the contrast enema. Imagine that the white areas is the polyethylene glycol. So this patient had a bowel movement after the contrast enema. This is the post-evac image, and you can see how he can retain the liquid. Then mom is going to call you. He's having more bowel movements 2 hours after the contrast enema. Yes, of course, because it's liquid. But these huge rocks are still impacted, are blocking the rectum and the sigmoid. And this is another case. Sounds like a worse case. This teenager, it was 11 years, he was taking polyethylene glycol for 8 years. He's not a Hirschsprung, is not an anorectal malformation, is not a patient with a neurological problem. It's an idiopathic constipation. So it's a big difference in versus constipation. So you have a spectrum. If the patient has a temporary constipation, mild constipation, without impaction, without fecal impaction, any kind of food is going to help. Any laxative, usually you can use osmotic laxatives. The patient is not going to have soiling, no social problem, and we call this the benign sign of the idiopathic constipation. In the other side is the patient that has already many months or years with constipation. He was already submitted to manometries, Botox injection, tons of polyethylene glycol, right? Mom has tried all types of diet trying to improve the constipation, and the patient is soiling, is having accidents, fecal accidents, and is a patient with important social problems. So this patient is not accepted in the school because the patient smells a poop. If you do a contrast enema in this group of patients, you will see a big rectosigmoid. This is a concept that I like to mention in this situation, and I call this pseudo-Hirschsprung. Also, many years ago, in the hospital where I was working, a group of surgeons, my professors, they said, this patient is a patient Hirschsprung, no Hirschsprung. So everybody was, what? Yeah, it's a patient with Hirschsprung, no Hirschsprung. So nobody understands what is that. Pseudo-Hirschsprung is a fake Hirschsprung. In other words, it's a patient without Hirschsprung, right? With constipation, which is common. Remember the three circles around the constipation? So it's a patient with constipation, but this patient has ganglion cells in the rectum, okay? However, also the patient is submitted to a surgical procedure for Hirschsprung. So it's a patient with constipation, with ganglion cells, and the patient has an operation. He can have a Duhamel, he can have a Suave, he can have a Swenson. This is a pseudo-Hirschsprung. I'm going to explain this more in detail. Why are there cases with pseudo-Hirschsprung? Why we are seeing patients with pseudo-Hirschsprung? Number one, the patient with idiopathic constipation do not responding to a standard treatment. We don't know what is the standard treatment. We have many patients with Malone's because they did not respond to the standard treatment. For constipations, there are no standard treatment. Standard treatment is a phrase that you please stop to use the standard treatment for constipation. That doesn't exist. Number two, When you have a patient with constipation and an unsuccessful medical treatment, this is going to produce desperation in the surgeon, in the mom, in the family, anxiety, and they want to know what is happening. Why my baby, why my son is having this constipation with fecal soiling, diapers, and the patient is 10 years. So the consequence is that the parent and the physician trying to explain and trying to find the cause of the constipation. So they try to do manometries, colonoscopies, Botox, etc., etc. And one of the studies is the biopsy. And another study is the manometry. And the manometry in patients with very dilated rectums are not useful. Patients with constipation and huge rectums, the biopsies are not very easy to perform. So the most frequent fault is an error in doing or interpreting the rectal biopsies and the contrast enemas. We have seen many patients with idiopathic constipation where the rectum is dilated, the sigmoid is dilated, looks like a mega-rectum sigmoid, and the radiologists report ultra short Hirschsprung or Hirschsprung only, which is very, very dangerous because now the physician is going to say, this is the report, now the patient has Hirschsprung. And the patient is going to be submitted an operation for Hirschsprung, Suave, Duhamel, or Swenson. This is the trap in patients with mega-rectum. If you have a very dilated rectum, even when you inflate the balloon with 10, with 20, with 30, with 40, with 60, with whatever, you are not going to be able to produce the stimulation of the rectum. In order to have the reflex, you must dilate the balloon and then you must dilate the rectum. This is the trap. And then the report is there are no reflex, so the patient has Hirschsprung. This is a trap. When you have this type of rectosigmoids that can accumulate a lot of poop, is because this portion is not working properly. The motility of this segment is very, very poor, and you are not going to have good results. This is a specimen, a surgical specimen of a patient with idiopathic constipation, and you can see this is the left column right here. So this is proximal and this is distal. Can you believe how can you stimulate this piece of bowel with manometry? I think it's impossible. These patients had a manometry and it was diagnosed with Hirschsprung. This operation is not for Hirschsprung, it's for other reason, but was sent to our service with the diagnosis of Hirschsprung based on a manometry. Same thing. This is a contrast enema. If the radiologists, they don't have experience, they can say, oh, this is a short segment or ultra short segment. This is another trap, and you can have a big error if you believe in this report. Another trap, you can take the biopsy, but if the biopsy is very superficial like this, just the mucosa, and the pathologists, they don't have experience, they can say rectal biopsy without ganglion cells, obviously, because the ganglion cells lives here in the submucosa and in the Auerbach plexus. So a superficial biopsy is another trap that can produce pseudo Hirschsprung patients. A good biopsy, now, very nice biopsy. The problem is that the pathology only performs few histological sections. And then even when he reviewed 1, 2, 3, 4, 5, 6, 7, 8 slides with calretin and whatever it is, they don't see ganglion cells. Confusion is Hirschsprung, trap and error. This is a patient with idiopathic constipation after a Swenson pull-through. So they remove the rectum, the sigmoid, and they mobilize the left colon, and they perform the pull-through. They did the anastomosis very, very low, like a Hirschsprung. Now the patient lost the natural reservoir, and you can see this complication. The patient is now fecal incontinent. Idiopathic constipation usually start very early in life in many patients, usually when they are 6, 7, 8 months. Is allergy. Allergy to proteins, allergy to milk, allergy to lactose, allergies. And they try to find many explanations. And you start with prune juice, you start with polyethylene glycol, you start with milk of magnesia, you can give lactulose, whatever. And the patient start to have bowel movements, which is what the parents want to see. They want to see poop in the diaper. Over the years, this is not a good medical treatment. And then this patient is going to have complications. Mega-rectum sigmoid, gigantic mega-rectum sigmoid. You cannot believe the size of the rectum and the sigmoid in some patients. So Hirschsprung versus constipation is a completely different problem. Please try to avoid this situation. If you look at this picture, you cannot believe if the patient has Hirschsprung. Obviously, no, this patient has constipation. The next conference is about the surgical treatment of idiopathic constipation. Now I'm going to share again my screen. Okay. Constipation, number one, we already said, is a common problem to different diseases, to different entities. Anorectal malformation, Hirschsprung, hypothyroidism, whatever. Now, I'm going to talk just in patients with idiopathic constipation, the surgical treatment of idiopathic constipation. The surgical treatment of idiopathic constipation is something that should not exist, something that we don't have to do that, because idiopathic constipation is a medical treatment. So why we need to do a surgical procedure in these patients? The response is very easy, because these patients had a very bad medical treatment and they have complications. That's why many patients with idiopathic constipation ended up in the OR doing with a procedure. Just to remember, idiopathic. Idiopathic means we don't know. We don't know why the patient is constipated, even when the patient already had tests for allergies, manometries, colonoscopies, Botox injection, everything. And the patient is still constipated. You already did everything. So this is idiopathic constipation. By the way, is the most common type of constipation. Is not constipation related to anorectal malformation, is not constipation related with other entities. This is the most common cause of constipation. The word impaction means a condition where something is pressed together, okay? So you can impact, let's say, almonds, you can impact sugar, you can impact chocolates, you can impact whatever. So is you are pressed these products together and then are fixed, okay? Like this diagram, this illustration right here, sorry, right here. So you can see a lot of cars here from everywhere. How can you move these cars? It's impossible, right? What happens in patients with idiopathic constipation is the rectum has fecal impaction, has feces accumulated in some way that produce a blockage, not a complete blockage. Sometimes it's a severe blockage, sometimes it's partial blockage. And this is the X-ray that I already showed you. So you can see a lot of poop in the rectum, sigmoid, left colon, etc., etc. This poop that you can see is not in the right colon. This stool is in the sigmoid. So if you give something like polyethylene glycol in this patient, the consequence is that the patient finally, thank God, the patient is going to have a bowel movement. Yes, but it's fake. It's polyethylene glycol. It's not these hard balls of stool. Before I explain surgical treatment, I think it's fair for my patients, for your patients to understand what you need to do first before you decide to take the patient to the OR. Number one, if you have a patient with idiopathic constipation, you need to have at least one X-ray. Ideally, you need to have a contrast enema. Most of the patients have fecal impaction. They have rectal impaction. A lot of poop in the rectum. So the step number one is to do a clean out of this segment. You need to clean the rectum. How are you going to clean the rectum? Is your preference. Our preference is we start with enemas. The enema is with saline and glycerin. If the enema is not producing a real bowel movement, then we take the patient to the OR and we manually do digital fecal disimpaction. Another option is to place a nasogastric tube and give polyethylene glycol with electrolytes. I don't like this last option because not all the patients are able to move the real stool that is impacted, blocking the rectum. The patient start to have bowel movement because it's just a lot of polyethylene glycol with electrolytes and has bowel movement. So the other reason is if the patient with this condition is going to have, if he already had one fecal impaction, the possibility to have another fecal impaction or 3 fecal impaction is really high. So the parents need to know how to do a clean out. At home, it's very easy to do enemas, but it's very difficult to say, okay, mom, place an NG tube in John and then give through the NG 4 liters of polyethylene glycol. This is very, very difficult. So the reality is mom is going to be able to do enemas at home, but an NG with PEG at home is not feasible. But the enemas is a home procedure. That's why is my preference. Even when the patient, sometimes I said, this patient is going to need OR, is going to need fecal disimpaction. I do enemas, at least for 1 or 2 days, just because I want to teach the parents how to do the enemas. Then I said, oh, I'm sorry, 2 days with enemas is not working. I'm going to do a fecal disimpaction in the OR. But already the parents know how to do enemas. This is very, very important. The step number 1 is the most important. The step number 2, you can continue with enemas before give laxative, because patients with long-standing constipation, with many years with constipation, with soiling, with diapers, with using diapers or pull-ups, etc., and they are 6, 7 years of age, 4 years of age, they need to know that they can stay clean. Even more, most of these patients also have pseudo urinary incontinence because they use diapers. So because they use diapers, it's very easy to pee on the diaper because they already use diapers because they had fecal incontinence, encopresis, pseudo-fecal incontinence, etc. So what I recommend is keep the enemas for some time. You can do it for weeks or some months, just to teach the parents and the patient that he can be clean without diapers. And the parents came with us again saying, no more diapers, and he is peeing on the toilet. He has urinary control, and we are very happy with that. Once the patient has urinary control, etc., then you can start using laxatives. The laxative that we use is an stimulant laxative. In the world, the only laxative that produces only a stimulation in the large bowel is Senna. Other stimulant laxative also stimulate the stomach, the duodenum, the small bowel, and the large bowel. In patients with constipation, we want just to stimulate the colon. We will just want to stimulate the large bowel. We don't want to stimulate the small bowel. That's why we use Senna and many other reasons. The step number 4 is to follow the patient. You cannot do the clean out one day, send the patient with Senna, and then the next appointment in your clinic in 6 months or 3 months, because this patient is going to have another fecal impaction. So the follow-up is very, very important. Some parents, when we have 1 year giving Senna, they say, for how long we need to give Senna? Probably for another year or another 100 years. They are very upset with that, but we always explain the reason. When some parents want to stop the laxative on their own, usually the patient come back again with fecal impaction. To reduce the amount of Senna, the amount of laxative, is very difficult. Should be very slow, and you need to follow the patient every day, because to fail in this winning trial is very common. The surgical treatment is reserved for special cases. In our experience, we have tons of patients, many patients with idiopathic constipation in our clinic, many. Less than 1% require a surgical treatment, which is very, very low. Finally, in red, if you are dealing with a patient with chronic, long-standing constipation, please do not use polyethylene glycol. If you have a patient with months or years with idiopathic constipation, with many problems, please don't use polyethylene glycol. How can you use this table? This table, you can take a photo, whatever you want. because it's very useful. This is the day when you are going to see the patient for first time. If you are going to see a patient with idiopathic constipation here on day one, on your clinic, in your hospital, when in the place where you work, you are going to see the patient with a contrast enema and an X-ray. You need to give education to the parents. If you want to give education family by family, that's fine. If you want to collect 3 families or 10 families, that's perfect. The parents need education. They need education. If you don't provide education to the parents, you are going to be very unsuccessful in the bowel management of constipation. Then, after the evaluation, you can do whatever you need. Step 1, clean out, enemas, OR, whatever. Then you can start with enemas if you want to start with enemas. Then you can start with a laxative trial. You can give X amount of laxative and see if this amount is working. But the most important, for the next following days, you need to have daily X-rays in order to evaluate your treatment. There is no other way. Mom can call you and say, oh, he had a big bowel movement, the biggest bowel movement in the world, is the big poop I have seen in my life. And then you take an X-ray and the patient still have a lot of poop. So this is very important. So you can do this every day. So you can have very good communication now with emails, WhatsApp, phone calls, whatever you need, and the resources you have. Usually very early in the morning. If you are working with a team, with another physician, with your nurse, whatever, you can discuss every day. And then you need to call back to the family. You can have another clinical appointment. Now you can have telehealth. You can have any type of communication and discuss with the parents every day the X-ray and the response of the enema or the laxative. And this is going to happen every single day. Sometimes you find the adequate amount of Senna or the adequate enema for the patient on day 3, on day 4, and that's enough. Usually that happens around these days. The problem is why a normal colon becomes this abnormal colon, abnormal rectosigmoid. Again, because the patient didn't have a good bowel management. This is the contrast enema in a normal patient, okay? And this is a contrast enema in a patient with mega-rectosigmoid after many years of unsuccessful medical treatment. Now, surgical treatment. There are many ideas how to help surgically these patients. Anal dilation, somebody said, probably is the sphincter is spastic, and you take the patient to the OR and you use the Haggard number 8, 9, 10, 11, 12, 16, 14, 22. Didn't work. Myectomies. Okay, the idea to cut the muscle in the anus or in the anus and the rectum is another idea. Botox, we can denervate the voluntary sphincters. Yes, if you use Botox in these patients, what you are doing is doing a denervation of the external sphincters, the parasagittal fibers, everything you know about the anorectal malformation. If you denervate these muscles, then the patient is going to have fecal incontinence and is going to have bowel movements. It's not a treatment, because the problem is not in the sphincters. The problem is in the motility of the colon. The colon already lost the motility. So it's another idea. The most common procedures that we perform with some frequency, I want to say, is resections and creation of AC procedures. As you know, Andrea is going to talk about the AC procedures. I am not going to stop on this. It's just to give the enema through the belly button, neoappendicectomy using a flap, patient without AC, patient with AC. We have a conference with Andrea about these procedures. Okay. Then, if the sigmoid is huge, is big, and is accumulating a lot of stool, and the patient requires big enemas every day for 7, 6, 5 years, then the parents are very tired. They say, we don't want to do more enemas. Is there any way to remove this huge segment? Yes, sigmoidectomy. So the idea to resect this portion is very good. So you can resect this portion, and then you have to do a very special anastomosis because the distal rectum is very dilated, and you are going to mobilize the left colon, which is usually normal in caliber, in diameter, and didn't match with this huge rectum. Some patients have good response to this sigmoidectomy. Some patients, the outcome is very, very good. But some patients, they don't have the outcome that we expect. The expectation of the parents when we do an operation is to cure, to resolve completely the problem. In patients with true, really mega-rectal sigmoid, and you just remove the sigmoid, in some patients, this segment, which is also very sick, is enough to produce again accumulation of stool. In other words, fecal impaction. And the patient is going to need again enemas or laxatives. If the patient after the operation does not follow the treatment, these patients probably are going to have fecal impaction. And we have many cases with this situation. This is a patient with mega-rectal sigmoid. This is the contrast enema. And this is after the sigmoidectomy. As you can see, the rectum is still big because we do not resect the rectum. In this just simple segment of bowel sometimes is enough to produce problems in these patients. Now the patient has only mega-rectum, not mega-rectal sigmoid. So this red dot is just to stress for you that when you do a sigmoidectomy, sometimes is not enough. So be aware of that. Some patients have very good outcome, some patients don't. You see? Another patient. This is the rectal sigmoid, it's in the diaphragm. So you are going to resect just this portion from here to here. Then this segment, the rectum, you don't touch the rectum because the sigmoidectomy is an abdominal operation. This is the anastomosis, beautiful, looks beautiful. Look the difference in the diameter. So the size of the colon that was anastomosis to the rectum is completely different. But this segment is not working. Don't squeeze, don't have contraction. So the risk to have, again, accumulation is high. Another problem that we have observed is when you do this operation, some patients, not all, some patients have abdominal pain in the left side. So if you connect a normal bowel with good motility in a segment that is almost paralyzed, with like a blockage, this colon has many contractions, squeeze, 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 and produce colicky pain. We had patients with this issue. Some patients require additional, another additional procedure, an AC. So the idea to do the resection of the sigmoid and then place an AC is a very good idea for some patients. So you have here the diagram of a huge mega-rectum sigmoid. Now it was resected. This is the anastomosis, and you place the AC, the Malone appendicostomy, whatever you want. So you can give antigrade enemas every day to keep clean this portion. This is another option that you can do in patients with mega-rectum sigmoid. Because the problematic residual rectum in patients just with sigmoidectomy, like this, you can see in this video, this is the rectum after a sigmoidectomy. So you can see how the contrast is back and forth here because this rectum does not squeeze. We are asking to the patient to have a bowel movement. He can't. The patient is not able to have a bowel movement. Then the consequence, the natural consequence, like a surgeon, we said, okay, because the sigmoid is sometimes not enough, let's try to do now the resection of the rectum. And in some time, a group of surgeons came with the idea to perform a transanal proctosigmoidectomy. In other words, like a Swenson operation in patients with idiopathic constipation. And they published this amazing picture in a patient. The consequence of this operation is that the patient is not constipated. The patient resolved the constipation. But most of the patient, if not all of the patient, now they don't have bowel control. We already hear from Dr. Peña that if we remove the natural reservoir, most probably the patient is going to have many bowel movements. Now you have a patient with hypermotility, and the patient is going to have this unfortunate complication, which is fecal incontinence. So we think if we remove the sigmoid only and leave the rectum, we have problems. If we remove all the rectum and we remove the rectum and the sigmoid, we have problems. So we came with a new idea. The idea was to say, okay, we have to remove the sigmoid for sure, but we cannot remove all the rectum. We have to remove some part of the rectum. We don't know if we have to resect 50% of the rectum, 20% of the rectum, 80% of the rectum. We don't know. Just because we believe that the rectum is important like a reservoir, we try to reduce the reservoir. If you want to do a partial resection of the rectum from above during this sigmoidectomy, the rectum is huge and occupy all the pelvis. All the pelvis is full of the rectum. So try to do the resection of the rectum from above is very difficult. Chances are to have lesion, injuries to the vagina, to the urethra, to the bladder, to the ureters, everything. You can damage everything. It's very dangerous. So what we came with the idea is to leave a short segment of rectum because we are very familiar with the transanal approach. We said, okay, let's try to do like a Revein or state operation with these ideas, you know, leaving a good amount of rectum, like 5 centimeters, 8 centimeters of rectum, doing transanal approach and full thickness. trying to keep the dissection very close to the wall of the rectum, which the rectum is huge. So you need to be very close to the rectum in order to avoid injuries to the pelvic structure. So this is one patient with this situation. We place the Lone Star, then we measure with a ruler the length that we want to leave in every patient. Usually, I want to leave between 5 and 8 centimeters of rectum. Then I take with a right angle, we take the very deep, the 8 centimeters, pull the mucosa and place the first stitch. So already have one stitch in the depth of the rectum. Once we have all the circumference, the distance from the anal canal to this here could be 8, 5, 6 centimeters. Then we start doing the incision here, and we try to find the plane of dissection in a full thickness. It's not a mucosectomy. It's like a Swenson. And this is the specimen in this case, in this patient. So this is the distal, the rectum, the sigmoid. And then this is the 5, 4, 6, 7 centimeters of rectum. You can see the difference in diameter. So this anastomosis is very challenging. What you need to do is to place 4 initial stitches in the rectum at 12, 3, 6, and 9 o'clock in the circumference of the rectum. And the same thing in the proximal bowel, 6, 3, 6, and 9 o'clock, to make a symmetric anastomosis. The anal canal, 5 centimeters of rectum. You need to be aware that you need to place 12 and 12, 3 and 3, 6 and 6, and 9 and 9 stitches to make a symmetric anastomosis. This is when we already finished the anastomosis, and this is the contrast study before and after the transanal operation. This is a diagram that I want to explain you the different options that we have. Number one, this is the patient before operation. This is the segment that you resect in the sigmoidectomy. So you leave the rectum. This is the complete rectosigmoidectomy. So you resect all the sigmoid and all the rectum. These patients are very good because they are not constipated, but they suffer involuntary bowel movements. This is the most recent operation we are performing that we call transanal, proximal, because we do the anastomosis and we do the resection proximal, not distal. That's why we call proximal, leaving this portion of the rectum. Again, in the sigmoidectomy, the limit of the resection is the peritoneal reflection. In the proctosigmoidectomy is the anal canal, and here is 5, 6, 7 centimeters of rectum. This procedure is a challenging procedure. It's not easy. I don't want to say this is very easy procedure. It's not easy. The problem in this one is that we lack the natural reservoirs, the rectum and the sigmoid, and the patients have involuntary bowel movement. In this one, the patients have bowel control, which is very good. We improve the constipation, which is very good. But if you left a very sick rectum, and we don't know when it's going to happen, then the patient is going to have again fecal impaction, sometimes abdominal pain in the left side, like an obstructive symptoms. In this group, this patient that we already have performed, I want to say most of them, if not all, are doing very, very good. Some of them are taking very low dose of laxative, like 15 milligrams. Few of them are not taking any medication. They are having voluntary bowel movements without enemas, without laxatives. So we are very enthusiastic with this procedure. There are two groups of patients that sometimes you are going to face in clinic. The patient that have neurological problems, usually autism, and patients without neurological problems. I said autism usually. If the patient is a normal patient, I don't perform an AC procedure. If the patient has suffering autism and other neurological problem, what I do is the resection and an AC procedure. You can type in the chat the questions, and it's 10:30. Now, the last conference before the break is the transanal approach. The transanal approach is something, it's a technical procedure not born with Hirschsprung. It was born before Hirschsprung problems. It was used by the adult colorectal surgeons for other reasons. We started to do the transanal approach for Hirschsprung in 1995. And then we learned many things about this approach. Now we use for Hirschsprung in some patients with idiopathic rectal prolapse and in patients with this common, I don't want to say complication, I want to say rectal prolapse could happen even after perfect PSARP in patients with poor muscles, in patients without sacrum, in patients with bad anatomy. So in 1996, after we learned how to do the Georgeson procedure, which practice in rabbits this assisted endorectal pull-through with my friend, Dr. Arturo Salgado, Ortega Salgado. And then in 96, we did the first patient. Then I have the fortune to see this patient again in the Instituto Nacional de Pediatría in one of the meetings in 2002. This is Dr. Jose Arturo Ortega Salgado in the Instituto Nacional de Pediatría.
We're not seeing Luis. We are seeing all your slides.
Are you what?
I think you were trying to show a picture, but we were seeing your presentation. Okay, now we're seeing the right one.
Okay, sorry. So this is Dr. Jose Arturo Ortega in the Instituto Nacional de Pediatría. This is Dr. De La Torre, very, very young. And this is the ideal case to do a transanal approach for Hirschsprung. If you have a ganglionic rectum in a newborn, in a patient with 3 months of age, you can start doing irrigation. You can send the patient home. Mom is going to enjoy his son or the daughter, whatever it is. And then the patient is going to grow. He's going to have yellow CD bowel movements with the irrigations. And then the patient is now 4, 5 kilos. And then you can bring the patient to the OR and you can do a beautiful transanal pull-through. And the rectal, full thickness, whatever you prefer. It's a very nice operation. I want to say that I love this operation for these cases. If you want to do an endorectal transanal, the most important thing in the endorectal is to find the plane of dissection, which is the submucosa. So you need to see the mucosa and then the circular fibers of the rectum. This is very clear here. You need to place your finger behind and make traction with this gauze. So one finger is pulling the mucosa and the other one is pulling the mucosa in front of your finger. So you can expose very clear the plane of dissection. This is a tip if you want to do an endorectal. This is the position how we do the transanal approach is the same like patients with anorectal malformation. I like to do anorectal dilations before the operation because create a more comfortable area to work. We start placing the hooks of the Lone Star in the skin to identify the anal canal. Then we recollocate the hooks more proximal or deep in depth to protect completely the anal canal. Then in the rectum, we place a suture. We usually use 5/0 silk with needle RB1 is what we usually use. So we place many traction sutures of 5/0 silk in all the circumference of the rectum. Once we have all these stitches placed, we start with a fine needle tip to cut just the mucosa for a couple of millimeters. So I want to say 3 to 5 millimeters. Then you can identify here the mucosa and the muscle. And then with traction, you are going to dissect the mucosa. These vessels are from the muscle to the mucosa. If you want to pull, you can perforate the mucosa. Look the finger behind always, and the other finger doing traction. This is the cuff. We place in every quadrant, one stitch taking the cuff and the mucosa, and then another stitch taking just the cuff in the 4 quadrants. This is the stitch mucosa cuff. This is the stitch only in the cuff. You can see just the muscle here. And then once you have these stitches placed in the 4 quadrants, you can cut in between, and then you are going to do a transanal laparotomy, a transanal access to the peritoneal cavity. So this is the sigmoid, and then you finish cutting all the cuff, and then the mesentery, you are going to face and look the mesentery in front of you because the mesentery is posterior. That's why we perform this operation in front. Once you decide to take the biopsy, you need to take a full thickness biopsy because we don't know if this patient has ganglion cells. We close this biopsy in 2 layers. So look the size of the biopsy, full thickness, then you need to send this in fresh. We close in our running lock suture the first layer. Then in using Lambert stitches, we do the second layer because we don't know if we need to mobilize more. Then we place stitches in the posterior wall of the cuff. Then we pull the cuff, we place this malleable, and then with the ligature, we cut and divide completely the cuff, all the length of the cuff until you reach almost the anal canal. I'm not saying you need to cut the anal canal, very close to the anal canal. And we call this the myectomy. So the myectomy here is done. You need to spread Then you need to replace the cuff because you don't want to have the cuff causing any blockage. The biopsy came with ganglion cells, no hypertrophic nerves. Then we take another 3-5 centimeters to do the anastomosis. So you can see the mucosa of the rectum here. This is the mucosa of the rectum, some millimeters. And we use 5-0 Vicryl to do the anastomosis, interrupted stitches in all the circumference. And the same thing, we try to do the first stitch at 12, the next stitch at 6. Look the mucosa of the rectum. And non-edited video, you can see this operation in YouTube. Then 3, you can see the mucosa right here. The anal canal is completely undamaged. This is the colorectal anastomosis. And then we are going to do the 9 o'clock stitch. And then the specimen, this one is the donut or the proximal margin, is what we studied to rule out transition zone during the pull-through. And then you finish the anastomosis, placing many stitches together, and this is the endorectal. Then you remove the Lone Star, and now you are going to see a Swenson, a full thickness. It's the same, the beginning is the same. Here you need to find the full thickness plane of dissection. You need to see and look and identify the fascia of the rectum, very similar or the same plane of dissection when you do a posterior sagittal approach and perform the dissection of the rectum to gain length for the pull-through in a patient with an anorectal malformation. It's the same plane of dissection. Once you find the plane, you need to pull. We are testing here with a lacrimal probe. You can use a mosquito, whatever. You can see the muscle. In the rectum, there is no serosa, it's adventitia. So you need to identify the adventitia of the rectum. Very important, keep the traction. Look how my colleagues are doing a very good traction. If you are doing a good traction, you can see the plane of dissection. This is the fascia of the rectum right here. This is a transanal Swenson. You can see here very clear. When you observe fat tissue, that means you need to be closer to the rectum. You need to be very close to the rectum. Fat tissue is adventitia. We are doing the dissection. You can see these bands how release the rectum and you obtain the length. Then when you have the dilated segment, you can cut the mesentery. We use the ligature for this step. So you can see the transition zone here, very clear. Again, the posterior face of the bowel is going to show you the mesentery. That's why for us is better doing this operation in a prone position. Once you are happy with the length, for us this was a transition zone. This looked like a healthy bowel. We took our biopsy. Again, very similar for the Suave. We close again in 2 layers, and then we do the anastomosis. I'm not going to show the anastomosis because it's the same like the Suave. Again, preserve the anal canal. Don't forget, if you don't preserve the anal canal, chances are that the patient is going to have fecal incontinence. This should be respected. Why we have patients with fecal incontinence? Because this is a suave, the classic suave from above, and this is, sorry, the suave and the Swenson. So you can see the cough, and this is how I did many cases open, and I have to prolapse the rectum, and it was very easy to identify the anal canal. So many years ago, we don't have patients with fecal incontinence after a pull-through. Now, with the transanal approach, this is the view. You are not going to do the prolapse of the rectum. So this is the view. This is the suave, and this is the full thickness. This is the Swenson. And this is the view at the beginning, so you don't prolapse the rectum. So once you are doing a transanal approach, the most important is to protect all these structures, which is the anal canal, placing the hooks deep to avoid the dissection of this area and leave good amount of rectum to do the anastomosis. The prolapse is a problem that you can see all over the world. There are many, many surgical techniques. And I found a paper from a surgeon in France. His last name is Delorme. And he was doing a very similar operation, a transanal approach, a mucosectomy for prolapse. And when I read the paper, and I had a patient with recurrent prolapse after 2 or 3 operations, came to me the idea to do the Delorme procedure. The Delorme procedure is for patients with rectal prolapse. And I want to tell you our modification only. It's the same thing. You need to place the retractor. You need to identify everything, the anatomy. And then the same thing. You need to place stitches all around in the rectum. Then you need, what I do is I leave 1 centimeter to be safe of the anal canal. This is all the stitches in the circumference. And then I do the mucosectomy. You can see here the mucosa. This is the cuff in case of Hirschsprung, but we are not going to cut the cuff. What we are going to do with the cuff is duplicate, duplication of this cuff. So you need to place the stitch in and out from the distal to proximal or proximal to distal in the 4 quadrants. Then you tie it, and then you place another additional stitch in between. This is the rectum when we start the mucosectomy. This is the rectum without mucosa, the naked rectum or the cuff, whatever you want to call. And then you cut here, and then you are going to do the anastomosis of this edge with this edge of the rectum. This is the anastomosis 12, 6, 3, and 9 at the end of the procedure, and then you return the anastomosis, and this is at the end how it looks like the rectum. I mean the anus. You can read the technique in this paper. It was published in 2019 in the Journal of Pediatric Surgery. And finally, before the coffee break, I want to show you what we are doing in patients with rectal prolapse after PSARP. In my opinion, this is not a complication. When the patient was born with bad anatomy, patient with rectal bladder neck fistula, for example, or bladder prostatic fistula, and poor sacrum, poor muscles, sometimes the prolapse happen. You can do this procedure if you want. I call this the transanal rectal mucosectomy, because what we do is the same like the LORM procedure. The difference here is that the patient already had a the skin anastomosis, because when you are doing the anoplasty in patient with anorectal malformation, you do the suture or the anoplasty, taking the skin to the rectum. The anoplasty is an anastomosis between the rectum and the skin. So, because we don't want to dilate this patient, we don't want to have stenosis or redo an anoplasty, I start to do the mucosectomy above the original anoplasty. So this is one case. So you can see here the sagittal approach, the scar from the sagittal approach, and you can see very clear the line of the anastomosis is between the bowel and the skin. This is the original anoplasty. What we do is we start the mucosectomy right here in this portion. Let's say 5, 8, 9 millimeters from the original anoplasty. Because it's very difficult to take pictures and demonstrate this operation, one of our medical illustrators, Nathan Bilton, which is an amazing illustrator, he worked with us here in Colorado, and these illustrations are very useful to teach you how to do this operation. So this line, this yellowish or more clear line, is with the letter B, is the original anoplasty. The C is showing the skin. This is the letter C, the skin. The anoplasty is going to be the letter B right here. And the mucosa of the prolapse is the letter A. So anoplasty, mucosa of the original rectum, and then many traction sutures, and then you are going to do a circumferential incision to do the mucosectomy. Once you have the mucosectomy, you can do 3 centimeters, 4 centimeters, 8 centimeters, depending on the patient and the length of the prolapse. Then you need to identify the circular fibers of the rectum. In patients with Hirschsprung, in patients with anorectal malformation, is a big difference in patients with rectal prolapse. Idiopathic rectal prolapse, the muscle is completely normal. In patients with Hirschsprung, imagine patients with anorectal malformation, the rectum is not, it shows a very tiny fibers, it's not hypertrophic. So you need to take care of that. You need to identify these circular fibers again. So again, the anoplasty, this is the rectum, and this is the mucosa that we already dissect. This diagram is to show you the original anastomosis, the mucocutaneous junction from the original anoplasty, the mucosa that we are leaving, because we don't want to dissect from here, is this portion. Again, this mucosa right here is this one. This is the rectum without mucosa. This is the mucosectomy, or the mucosa dissected from this portion of the rectum. Okay, we are here saying that we did an 8 centimeters of mucosa. You can do 3, 4, 5. And then we do the plication of the muscle again in the 4 quadrants, and then some additional plication stitches in between. And this is the illustration. Now look what happened when you tie this suture. This A is going to be very close to this A, letter A. So this point is going to be very close to this point. Look what happened. We start pulling and tying. So this is very close now. This is the plication. Once you finish to tie these stitches in all the quadrants of the circumference, then this mucosa is very close. Then you only need to cut and suture. Again, skin, the original anoplasty that you performed during the PSARP, mucosa from the original pull-through. The new anastomosis is bowel with bowel, not bowel with the skin. And this is the muscle that is plicated. And this is the same patient before and after the procedure. Now is a very cosmetic, to me, is like more aesthetic finish of this procedure. This is what happened when you do a pull through and you have invasion of the anal canal. You are not going to recognize anything, just mucosa and skin. Please don't do that. Okay, it's 11. Time for the break. Let's see if we can answer some questions, Andrea.
Yeah, there are many questions. So I'm going to start reading them in order. How do you decide on the length of mucosectomy?
In patients with idiopathic constipation, we usually do 8 centimeters. In patients with rectal prolapse, we start doing 8. Now we have reduced to 3 to 4 centimeters. It's just like that.
Is there a risk of obstruction when you do the plication?
No, we don't have any patient with obstruction with this operation yet. I hope we don't have any.
How long do you follow up these patients that you operate for prolapse?
The first patient that for prolapse was done in Pittsburgh in 2015. And so right now he has 7 years of follow-up. Is the longest follow-up. We don't have more longer follow-ups.
See. So about constipation, if a patient is on Senna after being disimpacted, passes stool every day, soft stool, but sometimes has diarrhea, should I increase the dose of Senna or give something with it? Decreasing the dose produces relapse.
We're talking about the medical treatment of constipation.
Correct.
You can answer.
Okay, so it will depend. The abdominal X-ray will help a lot in your decision. So if you're seeing that based on the X-ray, you cannot decrease the amount of laxative, then in order to improve consistency, you can add fiber. We recommend pectin. Here in the United States is Benefiber. It has no flavor, it's powder. So that improves the consistency of the stool when you just want a bulk, but you cannot decrease the laxative. So the X-ray will help you with this decision.
What is how many patients with functional or idiopathic constipation have a Malone? Okay, this is a very good question. In the United States, many patients have a Malone. The indication of the Malone is because the patient fails or had unsuccessful medical treatment to the standard treatment for constipation. The standard treatment for constipation in the US usually is polyethylene glycol, usually. I want to say more than 90% of the patients that are constipated in the United States, they take polyethylene glycol. It has different names in different countries. It's a pandemic problem, the use of polyethylene glycol. There are a very good paper that you must read. It was done by Dr. Carla Santos in the Instituto Nacional de Pediatría. And they compare the use of Senna versus polyethylene glycol. They demonstrate categorically, without any doubt, that polyethylene glycol is not useful for these patients versus Senna. In fact, they have to stop the study because it was not ethical to continue giving the polyethylene glycol in these patients. I'm going to type in the chat the reference so you can see the paper and you can read the paper.
Dr. De La Torre, about idiopathic constipation, there's a good question. It's a common question. Is it possible that patients with idiopathic constipation become unresponsive to Senna laxatives after a long treatment? And are there any secondary effects from the long-term use of Senna?
Senna is, Senna, as you know, came from the flowers, from the leaves of some plants. I am not going to give you the conference about Senna, but Senna is inactive. You need to know that. Senna is inactive. So you take Senna, is inactive. It just become active when Senna is inside the large bowel. So the bacteria, the fancy name, microbiota, the microbiota is going to change the Senna. Once Senna is in contact with the microbiota, Senna release a new substance. The substance is in the group of a very potent laxatives. The name is anthraquinones. So this component is in reality the substance that is going to produce the contractions in the bowel and is going to produce huge contractions. We have used Senna for many, many, many years. We don't have any patient with cancer, any patient with any side effect or big side effects. The problem with Senna in children that are on diapers is if the parents are not aware of the patient already has a bowel movement, they can have burns, they can have damage of the skin, very, very severe sometimes. Sometimes it's mild, sometimes it's very severe. It's like an allergic reaction based on studies of some dermatologists. Is something that happened in some patients, not all of them. We have used Senna in many patients, and we decide the amount. And then when we found the amount, let's say he's taking 75 milligrams of Senna. Usually, this patient with 75 milligrams is going to take forever, and it's rare to say in 10 years is going to need an additional Senna. The name tachyphylaxis or tachyphylaxia in Spanish or tachyphylaxis in English is when you reach the effect of a medication that happened, for example, with erythromycin in patients with gastric emptying delay. You need to stop for some weeks this medication. With Senna, we have not seen this effect.
Luis, one last question. I know we have to go, but how long do you keep your patients fasting or nothing by mouth after the DeLorme, after the transanal?
7 days.
Okay, perfect. I think we need a break now. How many minutes?
Yep.
How many minutes we're gonna have for break?
15.
The break is 15.
Perfect. Okay, so we'll see you all in 15 minutes.
See you in 15 minutes. Thank you.
Okay, I think our time has finished. We just need to see when Dr. De La Torre will be back. Let me just send him a message.
I just sent him a note, so.
Perfect. He abandoned the boat. If somehow he's unable, we can switch and I can do my lecture first. So let me see if he answers. And I think I'll give him 1 minute. And if
Okay.
he doesn't answer, I'll move to my lecture.
Sounds good.
He's running, he's coming. Okay, Dr. De La Torre is back and he's now gonna talk about Hirschsprung associated enterocolitis,
Thank you, Andrea.
irrigations, enemas, and Botox.
Okay, so these last two conference,
We are seeing all slides, not the presenter mode.
thank you, Andrea. These two last conference, to me, should be the most important. The first one is what we can do when you perform a perfect operation, technically well done operation in patient with Hirschsprung. And the second one, what can you do when you receive a patient operated by another surgeon in another institution and has damage of the anal canal and suffer fecal incontinence? So the first one is, what can you do after a beautiful, perfect operation? More or less 50% of the patient with Hirschsprung, after a good operation, we cannot solve the problem completely. More or less 50%, then we have obstruction or postoperative obstructive symptoms. We don't know why many things happen right now. The basic science are working really hard trying to explain what is happening. This is a perfect pull-through because the external sphincters right here are complete. The patient has a good sacrum. I'm very positive that this patient has a perfect muscular complex, parasagittal fiber, vertical fibers, everything is perfect. Not tethered cord. Is a patient that born just with Hirschsprung. And you did a complete resection of the aganglionic portion. You resect all the transition zone, the histological transition zone. So the anastomosis, you have here 2 millimeters of rectum in red. And this is the only patient that I know with true ultra short Hirschsprung. Because if you think in this patient, we are leaving 2 or 3 millimeters or 1 millimeter of rectum, which is this little portion, without ganglion cells. And I call this the true ultra short segment Hirschsprung after a good operation. And then I told you that the anal canal, which is all this structure, has Hirschsprung. Why this portion has Hirschsprung? Because this portion, the innervation, is abnormal. Dr. Arnold, yesterday, he explained very clear what happened in the anal canal. So the innervation is abnormal. And the scientific basis of the manometry in patient with Hirschsprung is because this portion, if you want to call the internal sphincter, you want to call the anal canal, whatever you want to call, is spastic. And even when you dilate the rectum, this portion is not going to dilate. It's not going to be open, it's spastic. So this little portion is still a problem. There are 3 residual problems in patients with a perfect pull-through: colitis, constipation, and no or almost no motility in the segment that we use for the pull-through, even when it has beautiful ganglion cells. This is a picture of a patient after a pull-through, no transition zone, very nice anastomosis, everything. But you can see the patient came to the OR because the patient is distended, is vomiting. The surgery was done 8 weeks ago. What happened? We don't know. This is an X-ray of this type of patients. Usually you can see gas. If you take a picture in a standing position, you can see here a level of fluid. Some surgeons call this the cut sign in the X-ray. But this video, I want to repeat this video because this video expresses most of the problem. I don't want to say this explains 100% of the problem, but most of the problem came just from this little portion that we left behind. So this picture, this video was sent from one of our patients, and the patient had a pull-through, and man was doing a dilation to help the patient to have a bowel movement. So look the video. Oops. This is the real colitis. Full smelling, bowel movement, explosive, that requires something to open this little portion of the anal canal. So, again, the anal canal, the colorectal anastomosis. This is a very nice anatomy. Again, now live. This is the anal canal that we need to leave. So in green, I want to stress that the green is completely normal, at least histologically is normal. The blue dot line is the anastomosis, and the red area is the obstructive area. Some patients, after the pull-through, can generate very good motility, energetic contractions of the bowel, and overpass this area with high pressure. 50% can do it, 50% they cannot. So it's kind of forces, pull and push. So the anal canal is pushing in somehow, just to illustrate this concept, versus the residual colon. If we have a healthy colon, most probably the patient is going to overpass this anal canal. If the colon, if the residual bowel that we use for the pull-through is not producing a very good motility, the anal canal is going to push more than the residual colon, and the patient is going to have obstructive symptoms. And this is the picture. So in this picture, this lady, it has more gym workout than this guy. This is a video of a contrast enema in a patient with a perfect pull-through. So you can see this is dilated, and look what happened with the contrast. The contrast is already in the rectum, in the near-rectum, but look the contraction. Instead, the contraction was huge here, and the contrast was back, another huge contraction. And this is the sign that we can see in the contrast enema in patients with colitis. You can stay there hours, and the patient is not going to have a bowel movement. Another contraction, nothing coming out. So you can see the rectum, the near-rectum try to have a bowel movement, but nothing happened. It has a huge contraction, the rectum right there, but no bowel movements. So in this video, you can see the obstruction is not in the colon. At least it has very good motility. It has very energetic, very strong contractions. This is just a picture of this study. So before you think that the patient has obstruction, you need to rule out mechanical obstructions and residual aganglionosis. In order to do that, you need to do 3 tests: an exam under anesthesia, a contrast enema, and you need to go back with your pathologist to review the proximal margin. The exam under anesthesia needs to identify the line of the anastomosis to rule out that there is no structure, there is no stenosis in this area. You need to exclude this problem. You need to evaluate the anatomy of the anal canal. Sometimes the patient has damage of the anal canal and stenosis. This is not common, but happen. Sometimes the patients had a bad operation. The surgeon did the anastomosis over the anal canal, almost is destroyed, but also has the severe stenosis. That's why you need to go to do an EUA. And then you need to take a biopsy of the near-rectum to be sure that the patient has ganglion cells. This is an EUA in a patient, so you can see all the anatomy, the skin, the anoderm, all the pectinate zone, and the neorectum. This is how a good operation looks like. The neorectum, this is kind of too much for me to in this illustration. The rectum, the aganglionic rectum, but it's very nice to illustrate where do you need to take the biopsy, right here in the neorectum. So this patient had a good operation, the rectum, the anal canal, and the biopsy of the neorectum. The contrast enema usually is going to show like a calicia in the esophagus. Remember the image in the esophagus when the patient has a calicia. So it's very similar to this one. There is no obstruction in the colon. I mean, no stenosis. So the medical treatment of the residual obstructive symptoms after a successful pull-through is the most important thing in patients with Hirschsprung. So all the surgeons must be expert in this medical treatment. Again, the keystone in this treatment are irrigations. So you need to know how to do irrigations. We have many videos, animations in our page from the Colorectal Center, and in my own page in YouTube, you can find many videos and explanations how to do irrigations. This is an X-ray on the left before and on the right after an irrigation. Just introducing the catheter in the colon, you are going to obtain stool, gas, etc., and you are going to decompress the patient. That's why the parents need to be expert doing this procedure. This is another video. I am not going to show you how to do irrigation because we already show you how to do it. We use always metronidazole in these patients, 10 milligrams per kilo every 8 hours for 10 days. If the patient is at home and the patient starts to throw up, to have bilious emesis or nausea or distension or abdominal pain, the patient is not doing well, our patients, our families are educated to do irrigations and then call or bring the patient to the hospital. Because sometimes the patient lives far away and the time between home and the hospital could be important, could be long, and then the patient arrive in the emergency department very sick. Once the patient is in the hospital, we do an evaluation. If the patient can go home because the patient is tolerating food, she knows how to do irrigation, we are confident with the family, then we send the patient home. If not, if it's the contrary, then we admit the patient, we do the rectal irrigation with the family, we put the patient in PO, IV fluids, the flagyl IV, etc., depending how severe is the patient. Laxatives. We use laxatives in patients with obstructive symptoms. Yes, when I will tell you later. Just I want to talk about laxatives because this is very important in all patients, constipation, anorectal malformation, and Hirschsprung. At least there are 4 main types of laxatives: fiber, the docusate, polyethylene glycol, and senna. All of them are laxatives, but everyone works different. In patients with motility problems, what we want is to motivate, to stimulate, to produce motility. In somehow, these 3 produce motility. And I call this like indirect. It's not a direct stimulation, like senna or bisacode. So this is our preference. We don't have dose for this laxative, for Senna. We guesstimate based on our experience, the contrast enema, the age of the patient, etc., etc. And we give it only once a day. It's not an antibiotic, remember that. So if you give Senna and the patient has 8 hours of bowel movement and the x-ray obtained after the bowel movement and is clean, look, there is no bowel, no residual stool, good. This is the amount of Senna that the patient needs. So if you are giving 4 tablets, 4 squares, whatever, and it's adequate, perfect. If the patient has diarrhea, many bowel movements, colicky pain, etc., the x-ray is clean, it's because you gave too much. So you need to reduce the amount of Senna. Instead of 4 milliliters, you need to give 3 milliliters. Instead of 4 pills, 3 pills, etc., etc. And again, you need to evaluate the 3. That's why you need to see the patient the next day. If it's adequate, you need to keep the same amount. If it's not adequate because the patient had a bowel movement or no bowel movement, but the bowel movement was very small and he has a lot of residual stool, the patient needs an irrigation and we need to increase to 5. This is how we work with the Senna. Botox. Botox could be controversial, could be denied for some surgeons, could be lovers. I know many people is Botox lover, others hate Botox. I want to be partial in this conference. Botox, as you know, is a toxin that produces chemodenervation. So the nerve endings are not allowed to connect with the muscle. That's why we call denervation. It's a chemical denervation, chemodenervation. So the muscle is not going to be able to have contraction. So it's going to be relaxed. What we want to do is to relax the anal canal. We don't want to denervate the skeletal muscle of the external sphincter, like the gastroenterologists use in patients with idiopathic constipation. In Hirschsprung, what we want to do is just to denervate the little portion that I show you in red in the illustrations. There are scientific, I don't know how they found the dose, 4 to 8 units per kilo. And you can dilute this in 4 or 8 to give in quadrants. This is the Botox that we use here in the hospital. A preloaded sterile syringe. I use 4 milliliters. I dilute the 4 milliliters and use 100 in patients less than 10 kilos. If the patient is more than 10 kilos, I always use 200 units. I use these 2 needles. One is the pink one. This 18 gauge is to dilute and prepare the Botox, and this fine, bitty, little tiny needle, 25 gauge, is used to inject the Botox. So if you are using 100 or 200, you need to put in quadrants, 25 here, 25, 25, 25, etc., wherever you want. It is very easy just to distribute by quadrants. I place my Lone Star. I identify, obviously, the anal canal. In a patient with destroyed anal canal, you don't need to use Botox. Please don't do that. So once you identify this, then the next step is, with this one, I'm showing the length, how I need to introduce the needle. So the needle, this is the line of the anastomosis. This is the anal canal. This is the zone that I want to inject the Botox. So it's almost a submucosal injection. If you go deeper, you are going to chemodenervate the voluntary sphincter, the external sphincter. We want just to denervate the smooth muscle of the anal canal. So I can feel with my finger the needle to be sure that is a submucosal injection. In this video, I'm going to show you how we inject the Botox. Remember, it's for the smooth muscle of the anal canal. It's not for the skeletal muscle of the external sphincter. It's for this area. Okay. The needle, I feel my needle, and then you will see the submucosal Botox right there. Another quadrant. So this is the segment, this area. You need to feel the needle very superficial, submucosal. And that's it per quadrant. Finally, I want to show you this image. Please observe here that this patient had a perfect operation. Now he has a J tube. Do you see the J tube here? It's clear. So this patient has already a cecostomy. This patient was sent to our center because the patient, after the pull-through, had many obstructive symptoms. The exam on the anesthesia showed beautiful, beautiful anatomy. Already had 3 Botox injections, no response. This is the cecostomy, and now the antegrade enemas. Every time he does the enema, nothing coming out, nothing. He doesn't have any bowel movement. So after this contrast enema, when we performed this contrast enema, all the contrast was stuck here and was moving to the right, like retrograde, backward, feeling even the ileum, you can see here. So we have to introduce a catheter, like an irrigation, trying to decompress the patient. This contrast you are looking here is from the small bowel. So we have to do like irrigation here, but you can see a flat, completely flat bowel. There is no haustra like this. And after the irrigation, look the edge of this bowel. This patient is a teenager, has suffering a lot. The antegrade enemas are not working, the rectal enemas are not working, the Botox is not working, it has ganglion cells. So this is a severe case of almost no motility. So I already showed you this problem. So this very simplistic diagram is to explain what can we do. Number one, always irrigations. If the patient has recurrent events of obstruction that requires irrigation and you have Botox, to me is a good opportunity to offer this option to the patients. Some patients have very good response to Botox. What is a very good response? The patient start to have bowel movement on his own, he start to pass gas, no more obstruction, etc., etc. So is the time to test the patient for laxatives or enemas. Sometimes after Botox, we keep the enema or we can keep the Senna. Some patients have good response to Senna, others have pain and they don't tolerate the Senna, so we keep the enema. If the patient responds to enema and requires a second Botox injection 3 months after the initial one, some patients have an AC procedure for the antegrade enema. Some patients, even after Botox and enemas and Senna, they don't have good response. So these patients require a resection of the bowel that is not working. And here, a good manometrist, a good GI with experience doing manometry in Hirschsprung is very helpful, just to identify if we are in the right thoughts. In the patient that I already present to you here, show you, this patient had a manometry before the contrast enema. And the manometry shows that all this portion does not produce any motility, is flat. So this is the case that we can do a resection because he already has an AC, Botox, etc., etc. So again, this is the patient with obstruction. We are assuming the patient had good operation, no aganglionic pull-through, so he can have constipation, Hirschsprung-associated enterocolitis, or no motility, or even both of them. So 50% of the patient will require this type, let's say, bowel management for patients with obstructive symptoms after a pull-through. Thank you again. And now, Dr. Bischoff is going to talk about what to do in patients with damage of the anal canal and suffer fecal incontinence. And we are going to leave the questions at the end. Go ahead, Andrea.
Just 1 second as I am trying to share my screen properly. Okay, I think I succeeded.
It's perfect. Yep.
No, something happened.
Oh.
Okay. So we're now going to talk about bowel management for fecal incontinence and antegrade enema procedures. I hope by the end of the course, you already know the difference between rectal enemas and rectal irrigations. And the reason why we have been repeating this concept is because frequently we realize people don't know the difference, and they are absolutely different. As the last time, rectal irrigation we use to decompress the colon from liquid stool and gas. In this case, what is gonna do the work is the big rectal tube, and we just use this small amount of salines to make sure that the lumen of the catheter is clear, it's not obstructed. So in rectal irrigations, we're injecting small volumes at a time and we are letting it drain through the tube. It's a mechanical thing. You put a little bit, but you expect much more coming out. So again, we just insert the tube and we want to see the fluid coming out. So this is just an animation to show you that we insert a big Foley and then we're going to let liquid stool drain through the catheter. And then when it stops draining, we are unsure if there is something clogging. So that's when we can inject a little bit of saline solution between 10 and 20 mL just to clear the lumen and let it drain more. So the goal of the irrigation is to decompress the colon from liquid stool and gas. Now, rectal enemas is a completely different thing. We are trying to actually clean the colon. So these are for patients that are fecally impacted or for patients that suffer from fecal incontinence. In that enema, we're going to
Andrea,
yes,
the
yes.
slide is stuck, so we are just looking the first one.
That is so strange because with me, it was sharing, it was moving. So let me try again.
Yeah.
Okay. Can you see now? Which
Now
slide?
we can see rectal enemas, an arrow, clean the colon, patient.
Perfect.
Yeah.
Okay. And did you see the animation or no?
No.
No, nobody looked the animation.
Okay, so let's go back and
Yeah, go back.
perfect. So again, rectal irrigation, we're just decompressing the colon, removing liquid stool and gas. So we insert the Foley and we expect the liquid stool to drain through the Foley. Can you see the animation now? So we are inserting the Foley.
Yes.
Yes.
Perfect. And we're gonna drain the fluid through the catheter. And then we're gonna inject small amounts of saline solution just to make sure that the lumen of our tube is clear, it's unclogged. So we inject just to clear the lumen because the liquid stool and the gas will naturally come through this tube. That's what a rectal irrigation is. And we have to think that patients with Hirschsprung, for example, patients that have not been operated yet, they have incapacity to empty the colon. So if we inject a large amount, we're going to do more harm. That's why we just want rectal irrigations. Now, rectal enemas is completely different. Now we're going to inject a large amount and the patient will contract and expel all the large amount. Completely different concepts, completely different indication. Rectal enemas are used for fecal disinfection or to clean the colon when the patient suffers from fecal incontinence and we want them to keep them artificially clean in the underwear, which will be the focus of this talk. So an enema, we're gonna use the Foley, we're gonna inflate the balloon to act as a plug, then we're gonna inject our solution. In 5 to 10 minutes, we ask the patient to hold that solution in place for at least 5 minutes. Then we deflate the balloon, the patient will sit in the toilet, and we're gonna let the patient empty for the remaining of the hour. So usually for 45 minutes. And the goal is that the entire left colon and the rectum will be clean. So there will be nothing to come in the underwear because normally the stool from the right colon will take 24 hours to move. That's for a patient with a normal colon. But we have to remember that here we are focused in patients with Hirschsprung. So the patient in the majority does not have the rectal sigmoid, but sometimes we have patients that only have the right colon. So in these patients, we will have a portion of the intestine, that it's the small intestine that always moves fast, and hopefully a portion of the colon that moves slow. So you will need sometimes a small and concentrated enema to clean that colon, and then Imodium, loperamide to slow the movement and to keep the patient clean. So that's why it's very important before we start bowel management to get a contrast enema. So we can see the anatomy, we can see how much colon we have. This case could be a patient that was operated for Hirschsprung disease because we see that we lost the curve of the sigmoid. So in this patient, we can see some contrast And these patients, when they have a non-dilated colon, they usually have a fast motility colon. This is not a case of Hirschsprung, but you're seeing a very dilated rectosigmoid. This would be a colon that moves very slow. So again, before you start bowel management, we want to know what's the anatomy of the colon. If you do the contrast enema on one day, the next day we're going to get an abdominal X-ray. If you still have contrast, you know this is a colon that moves slowly. If you don't have any contrast, you know that you're probably dealing with a colon that moves fast. So for the dilated colon, or you will need a large volume in concentrated enema. For the non-dilated colon, small volume enemas, just saline solution, constipating diet. Usually we say, and in the United States it's very hard, 3 meals per day, no snacks, because each time we eat, we have a tendency to, the gastrocolic reflex makes the colon move, so we'll have a tendency to have bowel movements. And if we're trying to avoid bowel movements, we want to limit the amount of meals per day. And as I mentioned, for patients that have a tendency to move too fast, the colon, we're going to add the loperamide, the Imodium. Now, what's the recipe of the enema? We don't have one generic recipe. It's by trial and error, and it takes us 7 days to find out the right enema for each patient. What's the base of our enema? We use normal saline. So if the patient has access to normal saline, they can buy it. If not, they can make it at home. You can do it with 1 liter of tap water and 1.5 teaspoons of table salt. So you're gonna mix, that's the recipe for normal saline. Then as the irritants, we prefer, our number 1 choice is liquid glycerin, and we use between 10 and 100 mLs. If we need more irritants, then we're gonna add something. In the United States, we have Castile soap. It's a mild soap based off glycerin. It has no smells, no flavor, no color. Flavor, I don't know, I never tasted. I'm sure it has. And then the last resource is the fleet enema. The fleet enema, we try to stay away because it's very irritant, but that one you must be careful and use it only according to the age of the patient. I don't recommend using fleet enema if the child is younger than 2. Between 2 and 4 years of age, I only use half of a pediatric fleet, so that's 33 mLs, just once in a day. Between 4 and 10, you can use a full pediatric fleet, that's 66 mLs. And if the child is older than 10, you can use a full adult fleet, that's 133 mLs. But the key here is, first, you can ask your radiologist how much fluid they had to insert to fill the colon. And you can start with at least 1/3 or less of that volume. Meaning if the radiologist said they need 1,500 to fill the colon, remember that they are really distending the colon. You can start with 400 and you will be fine. And then a little bit of glycerin between 10 and 20. But the key here will be looking at the abdominal X-ray one day and comparing with the other. Once you train your eyes, it's very easy to see stool in the abdominal X-ray. So let me just move here. So here you can see this granulation. This granulation here is stool, and the black is air. So here, this segment is clean. Here you can see stool, here you can see stool. In the rectum and the descending colon, you can see stool. And here are the staplers from the colostomy closure. That was certainly not done by us because we don't use staplers. So let's suppose that for this patient, the patient has damaged anal canal, was operated for Hirschsprung, suffers from fecal incontinence. Now we want to find an enema that given once a day will keep the patient clean in the underwear for 24 hours. So the patient comes, I look at the contrast enema, and I decided that I'm going to start with 400 mLs of saline and 20 mLs of glycerin. That's just an estimated guess. I don't know if it's going to work or not. And I tell the family we have 7 days to figure out. So they go home, they do the enema in the morning, sit in the toilet, and then they come to the hospital for an x-ray. I want to see immediately after the enema, was I successful in cleaning that colon? So now we're going to look at the rectum, compare the rectum here with the rectum on this abdominal radiograph. Yes, the rectum is clean. So now let's look at the left colon. Compare this one with this one. Yes, it's clean. So in this case, it's a beautiful radiograph. It's completely clean. So my guess was a success. So if the patient is clean and the x-ray is clean, I will tell the family continue the same. And you can see it's the same patient because you can see the stapler, the circular stapler right here, the anastomosis. So now let's see another case. Again, trial and error, 7 days, abdominal radiographs, and the key is to also listen to the parent's report. You want to know that you did the enema, patient had an evacuation, was within 1 hour, and that the patient is clean in the underwear. If the patient has stool accidents, we want to know what was the characteristic. Was it a large amount, solid stool? Was it immediately after finishing the sitting time in the toilet? Was it 12 hours after? All of those informations will help us to decide what's the next move. If the patient is having real stool accidents, it means we have to increase the concentration of the enema to clean the colon better. So let's suppose that this is the next patient. The patient came to you, you look, well, the rectum seems okay. I see stool here. I see some stool here. Well, doesn't look that bad. I'm going to do 200 mLs of saline and 10 of glycerin. Then the patient comes for the next day and you look at the x-ray. What do you think? Is this x-ray better or worse? It is definitely worse. So my evaluation that this was a mild case was wrong. This patient needs a way stronger enema. We need to clean. There's a lot of stool here in the left colon. There is a lot of stool in the rectum and plenty of stool in the colon. So again, let's make this as bigger enema and more concentrated. So I will try this one. I would do a big jump. I will go from 400. Usually we don't have to do such big jumps because we're good in predicting the first enema. But this one, I would say, let's go to 400 mLs of saline and 40 of glycerin. Then I'm going to see the x-ray next day, and I should see a clean colon. So that's how we do bowel management. This concept is very simple, and you just have to start doing. So you learn to train your eyes to see if you are making progress from one day to the other. And you only stop when the patient is clean. So let's suppose this is the patient that came to you. You say, well, I'm going to start with 300 of saline and 15 of glycerin. So in this x-ray, I see stool right here in the rectum, a little bit here, not too bad. The next day, is this better or is this worse? It's better, but it's not completely clean. And after the enema, I want to see a completely clean rectum and left colon. And here I still see some stool. So yes, I made progress, but it's not enough. So if I started with 315, today I'm going to tell the mom, let's try 330 today. And I'm going to see the x-ray the next day. So that's how simple bowel management is. Again, there's no magic formula. It's trial and error. And the key is to look at the x-ray and you want to see the x-ray immediately after the enema to make sure the goal of cleaning the rectum and the left colon has been achieved. Very important to have the contrast enema because especially in patients of Hirschsprung, sometimes the only piece of colon that you have is in this side. Then you need to know where you are looking in your radiographs. Now, once you have a patient that is completely clean in the underwear for 24 hours with once a day rectal enemas, as the patient grows old, they want to find out opportunities to do the enema in an easier way or a more independent way. We have some patients that do rectal enemas independent, but it's not that easy. Most of our patients prefer to go to the antegrade route. Very important, the antegrade route, it's not more efficient. It does not clean the colon better. It's just a door to deliver the enema. So again, the Malone procedure or the antegrade enema is not the treatment for fecal incontinence. The treatment for fecal incontinence is finding the right enema recipe. So here is how we do it. We connect the appendix to the umbilicus. That way the patient can sit in the toilet, pass an 8 French feeding tube through the umbilicus and give the enema in an antegrade fashion. We recommend to do it during the same amount of time. So, and here's how we do it. Once we identify the appendix, we want to look at the mesoappendix, that's the blood supply. So we create windows preserving the vessels, and then we're going to lay down the appendix towards the cecum, away from the ileocecal valve, and we're going to plicate the cecum around the appendix, almost like a Nissen fundoplication. So we use 5-0 silk for that. We get a bite in the cecum, a small bite in the appendix, making sure you don't touch the tube, that it should be already inside, and another bite in the cecum. And we're going to plicate this to create a valve-like mechanism, hoping to avoid reflux of stool out of the umbilicus. This is a study that Dr. Peña never published, but he did. About 50% of the appendix, they are naturally continent. So that means that 50% of them will have a tendency to leak. We prefer to plicate all cases and avoid that complication from happening. So what we do is in the deepest point of the umbilicus, it's going to be the tip of our triangle, of our V incision. And then we're going to open the appendix, the tip of the appendix, and we're going to put the tip of the umbilicus in the tip of the appendix and suture one side and the other side. So here you can see that would be the tip in the deepest point, and we're going to suture this side to this and this side to here. So again, now you're going to reconfigure the umbilicus, suturing this edge to here and this edge to here. And we like it to make it in a way that at the end of the procedure, it's almost invisible. Of course, not all umbilicus are made the same. Some of them are very flat and open, which is difficult to hide. But if you have a deep umbilicus, it's very easy to hide the Malone. And we keep the 8 French feeding tube for 1 month in place. After 1 month, the patient comes to clinic, we take this tube out, and we teach the family how to access daily. For the first 6 months, while the healing process is still happening, I like to keep something in place. So we used to have the ACE stopper. Now it seems to be out of the market. So we are just keeping a short piece of the tube with a little knot in the top. So I'm very proud of the Malones that I do. If the patient is thin, I can do with a very small incision and I make it very hidden. So that's one of my recent patients. Now, when I went to medical school, I learned that if you enter the abdomen of a child, you should just remove the appendix. Luckily, I think this concept has died and people don't do it anymore unless there is truly an appendicitis. But in the past, it was common that we would open the abdomen and we would not find the appendix. So we learned this technique. Dr. Pena taught me how to do neo-appendicostomies, and we use a colonic flap for that. So we identified a good vessel in the colon. Then with the bovie, we mark our flap. Then we open our flap, and then we insert the 8 French feeding tube, and we suture the colon, and then we're going to suture this flap around this tube. And then we're going to lay down, but when we lay down this new appendix, we want to lay down away from our sutures, because suture in front of suture has a tendency to form a fistula. So we're going to lay down away from our suture in order to create the plication. And then we're going to anastomose the tip into the umbilicus. So here is in a real case, we already marked our flap. Now we raise the flap, we suture the colon, and we're going to suture the flap around the tube. Then we lay down and we plicate, and we are ready to anastomose to the umbilicus. So that's what I had about bowel management for fecal incontinence. And I'm very happy to answer any questions, but hopefully after taking this course, you will all preserve the anal canal, because that's the most important message that we have. And you won't need to do bowel management, because your patients will have, and they should have, bowel control. Okay, Luis?
Very good. You have many questions. One of them is, if you need to do a clean out with enemas, is enough to do the clean out just of the left colon, or you need to do the clean out of the entire colon?
Depending for what you're doing. If you're doing a clean out prior to a surgery, for example, if I have to do a
After surgery to treat constipation.
Okay, so it's a disinfection. Well, in a disinfection, the infection happens in the distal colon. So it happens in the rectum, in the sigmoid, but you will end up cleaning everything. But what we are focused is to take the rectosigmoid portion out, the infection.
Mm-hmm. How about using 20 milliliters per kilo of saline during a washout? What do you think?
Yes, many people feel very concerned about having to guess the volume of enema. So I have heard people using 20 mL per kilo. If you want to try, it may work in some patients, it will not work on others. The key is to look at the X-ray and confirm that the enema is indeed cleaning the colon.
What do you prefer, or what is best, a cecostomy or appendicostomy?
We prefer appendicostomies because we don't have anything on it. So after the 6 months period, the patient has no devices. We see a lot of cecostomies with problems. For a cecostomy, there are many ways to do it. Sometimes it's done by interventional radiology, for example, and you need a constant tube in place. So there are more problems with leakage, with granulation tissue. So we are not big fans of cecostomy, and we feel that when they have complications, the complications can be very serious. So there's a question about patients that after the plication, if they have leakage, and what is our approach for that. Yes, there are some patients, and we reoperate on them, and then we find that the valve that we created simply disappear. So we create another valve-like mechanism. We try to use a different type of suture. We try to irritate the tissue a little bit, hoping to create that fibrosis.
What is the distance that you need to leave between the cecum and the side where you are going to fashion the neo-appendicostomy?
I don't have a measurement. I would say usually I do it probably 8 centimeters from it, but it usually depends on the anatomy. Once you look which one reaches well, which one has a good blood supply. I don't have a measurement exactly in my mind.
Have you ever closed an appendicostomy after total bowel control?
No, I have never, because my indication to open an appendicostomy is that the patient is truly fecal incontinence and depends on enemas to stay clean. So I have never had to close an appendicostomy. I would say it's not unreasonable to think that, let's say, a patient that had borderline bowel control was doing enemas and you did an appendicostomy and later the patient doesn't eat, you may just stop catheterizing and this may not cause any problems, or a closure would not be a problem.
Do you have experience using oil in the enemas?
I don't.
I think you answer everything, at least in this chat.
Perfect. So from my side, thank you everybody for joining us. Please stay in touch. We always announce our future courses. So we already have the dates for a family conference that is going to happen in November, and I'm going to post soon. And we also have the dates for the next Peña course that will be in person. We are still thinking what we can do, if we can do a also some portions virtual, but it's going to be from 5, 6, and 7 of April 2023. So thank you very much, and I'll let Dr. De La Torre finalize.
Okay, thank you, Andrea. In this, we start saying that in this crazy world, this type of events, I think is very good and provocative to continue working in pro of the quality of life of our patients. We hope, and it's our truly desire, that next year we can do a live in-person conferences, so you can come and we can have face-to-face discussions and fun and many things. I really appreciate more than 2,000 people connected yesterday. I don't know today, but yesterday were more than 2,000 participants. Thank you so much. You can see again all the conference through the Hendren Project web page. It's free. And Andrea and me and Alberto, we are very happy to answer any question. You can use our personal emails and we can advise anything and we can learn from you many things. Thank you so much and stay safe.
And a big thank you to Ray, who is the man behind the curtain.
Of course, Ray is the best. Thank you, Ray.
Thank you. Thank you all.